मग चालू करूया.
हो, करूया.
Good evening and very warm welcome to you all on the behalf of our ISA Mira Sangli branch. Today, we have very renowned faculties with us. Dr. Anita Nehte ma'am, who is a President-elect of SAM's office. Then Dr. Rajendra Nehte sir, who is a very well-known plastic surgeon and whom I have seen since my MBBS. I used to see posters at Nasik Civil Hospital. Then we have Dr. Sanyogita Naik ma'am, HOD of BJ Medical College, Department of Anaesthesia, and Dr. Gauri Ganga Khedkar from Tata Hospital. And very interactive and multi-talented moderators. Today we have Dr. Poonam Ghodke ma'am and Dr. Sujata Zine ma'am. I welcome you all and I request our branch president, Dr. Vasudha Jadhav ma'am, to brief about today's webinar. Over to you, ma'am.
Thank you, Rupali. Good evening, everyone. I welcome Dr. Rajendra Nehte sir and Dr. Anita Nehte madam, Dr. Sanyogita Naik madam and Dr. Gauri Ganga Khedkar madam on behalf of Mirror Sangli branch for today's session. I am really thankful from Mirror Sangli branch ISA for sparing your valuable time for us. Nowadays, you see all the plastic surgery and reconstructive procedures are performed in diverse environments. So just as plastic surgeries develop areas of specialization for better care of patients, so anesthesiologists also need to be specialized. So from today's various lectures, what we can learn at the end will be anesthetic choices available to the patients undergoing outpatient surgeries, various drugs and various techniques available for performing anesthesia, and also the safety measures provided for safe anesthesia as well as to minimize the post-operative, post-anesthetic problems like nausea, vomiting, and awakening, then a smooth induction and anxiety-related problems. So over to the नेक्स्ट काय आहे रुपाली, कोण बोलणार आहे?
मॅम मीच बोलते, शिल्पा मॅम नाही जॉईन
Okay.
होऊ शकत आहे.
So, over to Shilpa for further proceedings. Over to Rupali for further proceedings.
Yeah. Thank you, ma'am. Due
Okay.
to some problem, Shilpa ma'am is not able to join. So today we have Dr. Anita Nehte ma'am, who doesn't need any introduction, but as a part, I am going to introduce her. She is a MD and a DNB qualified anesthesiologist. She held many posts at ISA. Currently she is a president-elect of SAMS, then editor Misa News, president of ISA Nashik. She is a consultant anesthesiologist at Vedant Hospital. She has many achievements. She has invited as a faculty in various state and national conferences, and she is a reviewer of Indian Journal of Anesthesia. She is a certified trainer of Indian Resuscitation Council and Pediatrics and Perioperative Life Support. She has done many social works, working with Smile Train as an anesthesia since 2008, and she is an active Rotarian since 2016. Now I request Dr. Vinayak Patil sir to introduce our next speaker. Vinayak sir.
Yes, sir. Yes. Good evening, everybody. I welcome Dr. Rajendra Nehte sir to ISA Sangli Mirrors branch. He is a cosmetic hand and microvascular surgeon and is presently director of Vedant Hospital, Nashik. He has got various achievements. He is president of Indian Society for Surgery of the Hand for 2024-25. He is president-elect of Brachial Plexus Surgery Group of India 2023-25 and president-elect of Maharashtra Association of Plastic Surgeons for 2024-26. He is ex-president Asia Pacific Federation of Societies for Reconstructive Microsurgery and ex-president of Indian Society for Reconstructive Microsurgery 2022-24. He has got various awards. He is visiting professor in microsurgery of the year 2010, 11, 14, 15 by Associations of Plastic Surgeons of India. He has got various non-academic awards also, like Jeevan Sanjeevan Award 2024 by Deshdoot, Best Rotarian of the Year 3 times. He has got Lifetime Achievement Award by IIM Nashik and also Goda Gaurav Puraskar. He is not behind in various extracurricular activities. He is a trekker, mountaineer, marathoner, ultra cyclist, and photographer. And he is not behind in social work also. His hospital, Vedant Hospital, runs Smile Train project, and he is very active in Rotary Club of Nashik. I also like to give some different introduction. He is a friend of my classmate, Dr. Arun Kumar Deshmukh, plastic surgeon from Kolhapur, and Dr. Sharad Sawant from Sangli. Because they told me when Nete madam were contesting the elections, they told me to vote her. Proceed to
Thank you, sir.
Rupal ma'am.
Thank you, sir. Welcome, Nete, sir. Now I request Sunita ma'am to introduce our next speaker, Dr. Naik ma'am. Sunita ma'am.
Yes. Good evening, everyone. It's my immense pleasure to introduce our next esteemed speaker, Dr. Sanyogita Naik ma'am. Ma'am is currently serving as a professor and head of the Department of Anesthesiology at BJ Government Medical College and Sasun Hospital, Pune. She also holds the role of Nodal Officer of Skill Lab at the Medical College. She is an experienced trainer for the NELS, that is National Emergency Life Support Course. Her special areas of interest are obstetric anesthesia and various new techniques in the regional anesthesia. Today, she will be sharing her valuable insights on anesthetic considerations in chronic burn patients for aesthetic surgery. Please join me in welcoming Naik madam. Welcome, madam.
Thank you. Thank you, Sunita.
Now I request Ankita Gosavi to introduce our next speaker. Ankita? Ankita? I think, Ankita, are you audible? Okay. Sorry, maybe she's disconnected. It's my immense pleasure to introduce our next speaker, Dr. Gauri Raman Gangakhedkar, ma'am. She is a DA, DNB, fellowship in neuroanesthesiologist and currently working as an assistant professor in the Department of Anesthesiology, Critical Care and Pain Management at Tata Memorial Hospital. She has many publications, almost more than 40 papers in Index Journal and 7 chapters in books. There are many awards on her name. First prize at SOPACON 2018, BANET 2019, and GSA paper presentation 2019. She is a winner of ISA NAC quiz 2018. There is special mention about a award that is mentor in the WFSA Global Mentorship Program. She was a reviewer of Indian Journal of Anesthesia, Journal of Onco-Anesthesia and Perioperative Medicine, and Research and Innovation in Anesthesia, and clinical case reports. Her area of interest are onco-anesthesia, patient safety, non-technical skills in anesthesia, difficult airway, neuroanesthesia. Welcome, Gauri ma'am. Now I request Dr. Ruta to introduce our moderators. Ruta?
Hello, good evening, everyone. Am I audible?
Yes, yes.
Okay. Good evening, everyone. Today we have very learned personality as a moderator, Dr. Poonam Ghodke ma'am, and she is currently working as a consultant in the Department of Anesthesiologist in Dinanath Mangeshkar Hospital, Pune. She is EC member at ISA Pune City branch. She has worked as professor in the Department of Anesthesiology and Critical Care at SKN MCGH Pune, and she was a PG guide since 2015. She has many feathers in her cap. She has received BMJ nomination for Best Research Publication in 2017. So she has received Srimati Bhagirathi Award and GS Ambardekar Award for Academic Excellence Examinations 2007 in Mumbai. She is editorial board member of JACCR Research Journal SKNMC. She is reviewer for IJ, JOSCP, JNA, JACCR, Brazilian Journal of Anesthesiology. She has also received Certificate of Excellence Award for Best Reviewer IJ at ISACon 22 Shillong. She has received Pradnya Trophy for Best Paper Award in 2020 National Conference at SKN-MCGH. She is receiver of Dr. Lakshmi Kamath Award for Best Essay at ISACon Nagpur. Her Special Achievement Award, she has also got Special Achievement Award at MISACon 2017 Nanded, SAP 2017-18-19. She has also multiple national and international publications, and she has extracurricular interest in poetry. Welcome, Poonam Ghodke, ma'am.
Thank you, Ruta.
Now I request Sarika ma'am to introduce our next moderator. Sarika ma'am. Sarika ma'am.
Hello.
Ma'am. Yes, ma'am. You are audible.
Yes, okay. Good evening, everyone, all the dignitaries and my fellow anesthesiologists. Good evening, everyone. I'm here to introduce Dr. Sujata ma'am. She is our moderator today for today's session. She is consultant anesthesiologist in Ozone Anesthesia Group, Chhatrapati Sambhajinagar, that is Aurangabad. She is working as a GC member, elected as a GC member for year 2023 to 2025. She was immediate past secretary at Aurangabad Anesthesiologists Association for the year 2021 to 2023. She is life member of SOA PC. She has many achievements on her name. She was organizing secretary for ISA National Sponsored CME April 2022. She was organizing secretary for Difficult Airway Workshop in 2024 and President Appreciation. She has achieved President Appreciation Award for an Art and Literacy in State Conference 2021. She has highest proficiency award at ISA National 2022. She has conducted many state level CMEs for Anesthesia Association and Cardiologist Association. She has conducted many workshops on basic life support and COLS for public awareness. She has conducted workshops on hemodynamic monitoring in 2021. She has many awards and prizes on her name, as you can see on the screen. I welcome Sujata ma'am as a moderator for today's session. Thank you.
Now I request both the moderators to start the session.
Yes, good evening, everyone. We will start with Dr. Anita Nehete, madam, our president-elect of SAM. Madam will be talking about anesthesia consideration for cleft lip, palate, and recent update. Over to you, Dr. Anita, madam.
Yes, I'll start sharing.
Yeah, welcome, ma'am.
Can you see my screen?
Yes, ma'am.
Yeah. So I would like to at first thank ISA Miras Sangli branch for giving me this opportunity. And I sincerely thank Rupali, Dr. Vasudha, Sarika, Dr. Vinayak Patil sir, Shilpa and Manisha and ISA Sangli office bearers. And today I am going to talk on cleft lip palate, anesthesia for cleft lip palates. Yes, is the slide moving? Can you see the next slide?
Yes, ma'am.
Yes.
So let us see a case first. A case of cleft palate, 9-month-old child, 8 kgs, and the child is hypognathic and rest all is normal. Mouth opening, neck movements is good. When you induce this child with propofol and scoline, the mask ventilation is easy. On direct laryngoscopy, you find that epiglottis is seen, but the cords are seen intermittently on the strong pressure on the larynx from outside. So you try endotracheal tube number 4 and it is not going. So you ask for a smaller tube to your assistant. Now your assistant is fumbling with the endotracheal tube. He can't find smaller tube. He is trying to look at the number of the endotracheal tube and the saturation starts dropping. So hair raising situation, isn't it? So what will you do in this case? So really, are the cleft patients, cleft lip palate patients different than other pediatric cases? Are there different challenges? So yes, the challenges for anesthesiologist in a cleft case that every patient of a cleft needs the general anesthetic with endotracheal tube. There is airway sharing with the surgeon. The surgeon is operating in the mouth and your endotracheal tube is in the mouth. The cleft patients have a large number of syndromes. There is difficult airway and the post-operatively the airway might worsen because of the closure and airway swellings. So the cleft lip palate is one of the commonest congenital defect, and at Vedant Hospital, we have done more than 3,000 cases of cleft lip with the help of Smile Train Express. Smile Train Express is an American NGO, and they conduct comprehensive cleft care. In the sense, they conduct with the help of their partner hospitals. They are present in 85 countries, and these surgeries are done totally free of cost with the help of Smile Train. So the cleft can be a minor cleft like just a unilateral incomplete cleft, or it can be a bilateral and complete cleft. So increasing severity of cleft is known to increase the difficulties because the surgical time will also increase. The amount of bleeding also will increase with the increasing severity of cleft. So what are the challenges? These patients have multiple challenges in the pre-operative, intraoperative, as well as post-operative periods, which are unique to a cleft patient. So let us see one by one. So in the history, what we should see is if there is a history of failure to thrive or history of cyanotic spells, then you should suspect that the patient might have any congenital heart disease. The child has history of sleeping in prone position or snoring, then the child can have respiratory obstruction or a difficult airway. The history of URTI is important. And in examination, you look at the nutrition, presence of URTI, presence of syndromes, and whether the airway is difficult or not. So the nutrition is seen by these Z scores, which are given by WHO, and whether the child is has appropriate weight for his age is seen. Then again, anemia is a sign of poor nutrition. It can be nutritional or physiologic, but it can be rapidly corrected by oral iron supplements and deworming. So the acceptable lower hemoglobin at our center for cleft lip is 8 grams, and for cleft palate, even 9 grams we accept. Because the blood loss per patient is very less, around 5 to 10 cc only is a small blood loss. So we don't even reserve blood for these patients. But of course, it depends on center to center and depends on surgeon. The protocols are different. So presence of URTI is very important. These patients have more frequent URTI because of mixing of food and air in their pharynx. And what happens with URTI is the airway becomes hyperreactive, and more hyperreactive airway will lead to a more incidence of post-operative respiratory adverse events like post-operative laryngospasm or bronchospasm. So what to do if the patient has URTI? And what does the URTI mean? So conservative approach tells you that to postpone, because it's an elective surgery, postpone for 8 weeks. But then what happens when this patient will come again after 8 weeks? He can come with another episode of URTI. And so it is very difficult to get a disease-free window in some of the patients. So what to do? So when to postpone? Now it is very clear to us anesthesiologists that if a child is lethargic, has a florid infection, the child has high fever, purulent discharge, or a productive cough, or presence of rhonchi, then of course we would postpone this patient. Depending on centers, again 2 to 4 weeks. And if there is a pneumonic patch, then we'll postpone for 4 to 6 weeks. But there is a dilemma whether to postpone a child with just a mild running nose. And the parents will tell you that just today morning it started running. Just yesterday he was all right. Or a child might be taking treatment of URTI from beforehand and has no other symptoms. So whether to give this case or not. So the points here we consider are, if the child is looking active, then you can give the case. If this cleft is less severe, like it's just an incomplete lip, then you can give, because as the severity of cleft increases, the incidence of respiratory problems also increase. The lower the age of the child, increases the respiratory problems. So you can decide. And most important is the comfort and experience of the anesthesiologist. If you are an experienced anesthesiologist and you have a good setup and good assistance, you can go ahead with the case. But needless to say that every case should be individualized. Now coming to a syndromic child. The cleft is associated with a large number of syndromes, and approximately 10% of cleft patients have some syndrome or the other. So the commonest anomalies are limbs, vertebral columns, and cardiac. So we are more interested in the cardiac anomalies. And the serious problems are VSD, ASD, PDA, or sometimes cyanotic heart disease. So you should suspect that cyanotic heart disease may be present if there is a history of failure to thrive, or cyanotic space, or a low birth weight, or you can hear a murmur. Now it is very difficult to listen to a murmur in a child who is crying, thrashing, and tachycardiac child. So sometimes you can miss the murmur. So if you suspect that the child may be having congenital heart disease, then you should do a preoperative echo. And all patients who are diagnosed congenital heart disease must receive a prophylactic antibiotic to prevent a subacute bacterial endocarditis. Now, these are some syndromes associated with cleft lip and palate, and the Pierre-Robin sequence. It's not a syndrome, it's a sequence. So it is in Pierre-Robin sequence, there is micrognathia, glossoptosis, and respiratory obstruction. So usually Pierre-Robin children become more easier to intubate with age. As the age advances, they become easy to intubate. Unlike some other syndromes like Treacher-Collins, as the age advances, it becomes more and more difficult to intubate. And these are some other rare syndromes: hemifacial microsomia, velocardiofacial, or syndromes associated with the cleft. So whether the child is labeled as a Pierre-Robin or not, a child with an isolated cleft palate. Now, some of these children are labeled as Pierre-Robin, and some of them are just isolated cleft palate. But all of them can be very difficult to intubate because they are hypognathic and they have an anterior larynx. So how to do airway assessment in these patients? See, Malampatti is not of any use because the child will not cooperate, will not show you, open his mouth and show. So a history of snoring or sleeping in prone position will tell you that the child may have respiratory obstruction and a difficult airway. If there is a history of tongue-lip adhesion in neonatal period, usually the Pierre-Robin sequence patients, they can't breathe immediately after birth. So their tongue is stitched to the lip. And if there is such a history, then it indicates extreme difficulty in intubation. Presence of hypognathia indicates difficulty. But the good news is the majority of non-syndromic clefts are easy to intubate. And non-syndromic clefts means the clefts which have only a cleft lip and palate, or isolated cleft palate maybe, they are not syndromic. So they are easy to intubate with good assistance. And most of the difficult to intubate ones are easy to ventilate. So you can ventilate and come out of the situation. But of course, needless to say that it needs good assistance, and you need to train your assistants in this. So this is a Kopur scale, which tells you how whether an intubation will be difficult or not, and this can be the chin, the mouth opening, the previous history of intubations, and all such points are taken in this, and marks are given, and accordingly they decide whether the intubation is difficult or can be easy. Now, coming to investigation, generally we do routine investigation in these patients, and only if you suspect pneumonia, then you do X-ray chest, and only suspect congenital heart disease, then you do a 2D echo to rule out CHD. The NBM guidelines are, according to recent guidelines, you fast the child for 6 hours with the formula feed and any milk, cow's milk, and fasting for 4 hours for breast milk. Fasting for 1 to 2 hours for clear fluids like water. You can give glucose water 2 hours prior to surgery to all the patients. So this will reduce, especially in summer season, you must give clear fluids 2 hours prior, and you can give a glucose containing fluid to the child. Simple glucose water you can give. You must confirm the NBM status immediately before, because you know the mothers, when the child is crying, they sometimes feed the child, and then you can land in trouble. So you must confirm. Now, coming to anesthesia management, generally I give a pre-medication with oral midazolam to all children. If you are giving pre-medication, then you must observe these children in the pre-anesthesia room, and you must monitor their saturation. In any case, if there is such a facility is not available, then you should not give a pre-medication in the ward, definitely. Then intravenous pre-medication, generally I use fentanyl glycopyrrolate, and we tend to give a lot of IV drugs to this patient, which amounts to actually polypharmacy, but these drugs are very essential for a balanced and multimodal anesthesia and analgesia. So dexamethasone we give to all patients. This will reduce the swelling. It's an anti-inflammatory. It will reduce the pain and anti-emetic also. Tranexamic acid to reduce the blood loss. Ondansetron to reduce, again, anti-emetic. And dexmedetomidine to reduce emergence delirium and antibiotics. So you can induce the children under inhalational or intravenous anesthesia. If you give inhalation anesthesia, you can give a smooth inhalational sevoflurane after pre-medication. No need to force the mask onto the child. If your child is nicely pre-medicated, as you can see in this video, he will accept the mask and will go under very easily. Or you can give intravenous induction, and this necessitates the venous access before induction. So again, for venous access, you can give sedative pre-medication. The child will be quiet. Then put a Prilox ointment on the hand and distract the child. You can distract very easily with the help of mobile phones, cartoons, and but for good venous access before anesthesia, you need expert assistance. Sometimes the veins can be very difficult in these patients, and you need even gadgets like vein finder or USG guidance, because sometimes the veins are very difficult in a chubby child. So you need good assistance. Now coming to intubation, the difficulty to intubate non-syndromic cleft, like isolated cleft palates, is mainly because of hypognathia. And a hypognathia, you can easily, the solution to this problem is giving an anterior pressure and using a video laryngoscope. So in this video, you can see that the video laryngoscope is used. It's a Macintosh type video laryngoscope, and you can see that even if you can see the cords are somewhere anterior onto the screen. So for your tube to reach the cords, you need a stellated endotracheal tube. The tube tip to reach the cords, you need to have a stellated J-shaped endotracheal tube. Then it will reach, and your video laryngoscope use will be successful. So this can be used. And if it is a left-sided alveolar cleft, then again the problem is because the laryngoscope blade is sliding into the cleft. So what you do, you put a roll of gauze into the cleft and you rest your laryngoscope blade onto that roll of gauze, so that you get a good laryngoscopic view. And if it is a bilateral cleft, there is a prominent premaxilla, and that premaxilla itself can come in your view and obstruct your view. So here also you can see that you need good assistance. The assistant is giving anterior laryngeal pressure. and even retracting the left lip. So coming to difficult airway card, this has to be ready in any patient who you suspect that the intubation will be difficult. And it should contain all smaller size endotracheal tubes, steelets, proper size oral nasal airways, straight blades, videolaryngoscope, Macintosh type or the tunneled one, channeled one, like air track, and all LMS, proper size LMS, lipothyroid kit, etc. All this difficult airway card has to be ready if you suspect patient might have a difficult airway. Now, what they say is if you predict a difficult airway, then you must keep the card ready, no doubt about that. A second anesthesiologist will be very helpful. Because if you are doing a case alone in a nursing home, then it will be sometimes very difficult for you to do everything alone and you will be stressed out. So having a second anesthesiologist or having a very good assistance is important. Inhalational induction is preferred because you keep on spontaneous. But again, what happens when a moment you remove the mask, the child becomes very light on sevoflurane. So some people prefer to give propofol, a small propofol IV to keep the child under and keep on spontaneous. If it is a predicted difficult intubation, you can use choline. So that you must always confirm if ventilation is possible before giving any relaxant. So you mask ventilate and see that the child is getting ventilated. A nasal insufflation of oxygen. So how this is done? You put nasal cannula and another oxygen source you put and give a continuous source of oxygen with 3-4 liters of oxygen. So this will flush the pharynx of the child with oxygen and it will give you some more time for your apneic period. The desaturation will not occur so fast. Another important thing is you should limit the number of attempts at intubation, and the second and third attempt should be done by a senior anesthesiologist. So you intubate with a RAE tube, which is a south pole tube, and a microcuff tube is preferred. It is a soft silicone cuff. And otherwise, if you don't have a microcuff, then you can use a plain tube also. The positioning of the child is important because intubated child, you have to give extension of the neck and head, and then you fix the tube. If you fix the tube prematurely, the tube will move when you are giving position. So all this is very critical. There is movement of the tube after giving neck extension. The maintenance is usual. You can do oxygen, air, or plus nitrous and sevoflurane or isoflurane. I use cisatracurium as a relaxant, I prefer. And intravenous fluids, generally we give ringer lactate by a burette set. A burette set of 100 ml is important because if by mistake somebody leaves the IV set open, the whole big volume doesn't go to the patient and only, or you can just take 50 ml in the burette set. And you will not load the patient with a huge volume. Addition of glucose is if you are giving a nerve blocks, like the maxillary nerve blocks, what I have seen is that the patient is so much pain-free that the stress response to surgery absolutely vanishes and the patient actually drops his sugars. So sometimes I have seen a sugars of 50, and that is why if I give a block, maxillary blocks, then I use 2% of ringer lactate, 2% dextrose I add in the ringer lactate solution. Then throat pack is done usually by the surgeon because the surgeon puts the Dingman's cannula, Dingman's clamp, and then surgeon does the throat packing. The monitoring of intraoperative events, certain events are very important and these are special for the cleft patients, is that the Dingman's gag. When the gag surgeon is putting, there is a lot of head movement and the tube also can go inside or become endobronchial or tube can come out. Then another event is a local infiltration by the surgeon. There can be sudden tachycardia, there can be intravascular injection of adrenaline or the local. So you have to be there and you have to be monitoring all these events. The blood loss you need to monitor. Because it's a pediatric patient, hypothermia is important to prevent, and you can control the ambient temperature or use a forced air warmer to prevent hypothermia. The calculation of blood loss is difficult in this patient because there is no lot of blood loss, and the equivalent blood loss also is very less. So what we can do is we can actually weigh the gauze pieces beforehand and after and see the difference, and then you'll come to know what is the blood loss in this patient. Now, after the surgery is over, there is you must carefully do throat suction under direct laryngoscopy to find out whether there is a hemostasis achieved, if there is any bleeding inside, and to suck out the clots. Now, if you want to do laryngoscopy, direct laryngoscopy, at the end of the surgery, you need to keep this patient deep. So you have to give 1 dose of propofol or keep the patient deep and do this laryngoscopy. Remove throat pack, ensure hemostasis, and then reversal of block as usual. Now, whether to do awake or deep extubation is again controversial. I usually prefer slightly deep extubation, and then I do a post-oxygenation with 100% oxygen. And immediately after extubation, give lateral position, post-tonsillectomy position to this child, so that if the child is having some bleeding, it can come out and it can maintain its airway better in the level position. Now, the post-operative analgesia. We give multimodal analgesia, and what it includes is that intraoperatively we are giving opioids, that is fentanyl, and either the anesthesiologist or the surgeon is giving blocks, local infiltrations, dexamethasone, dexmedetomidine, and the post-operative period, a paracetamol suppository, and then the oral ibuprofen syrups. So this is the, in short, plan, multimodal analgesia plan in a cleft patient. And the blocks for cleft lip, we give infraorbital blocks. For palate, we give by maxillary nerve blocks, or the surgeon can give greater, lesser, or nasopalatine blocks. Needless to say, we must watch for the total dose of local anesthetic that we are giving. So this is a video of infraorbital block, and see, the patient is intubated. So you, if you want to, your direction of needle, watch how the needle is going. So you need to sometimes push the tube on one side, and your aim where you want to reach is here. This is the infraorbital foramen, and around here you should inject. So your needle shouldn't enter the orbit. It should remain here on the bone maxilla. So you need certain adjustments for that. So you must aspirate before injecting, because the bundle, neurovascular bundle is there, and it can become intravascular if you don't aspirate. The buprenorphine 0.25%, 1 to 1.5 cc at each site is sufficient. Then this is a new, it's a UAG guided bilateral maxillary block, which is a suprazygomatic approach. So you saw that you are placing the USG probe under the zygoma, and you are looking from under the zygomatic bone towards your needle, and you are looking at the pterygopalatine fossa. So this is the pterygopalatine fossa, and you can see that the movement of the fluid, you can see here when the fluid is getting injected, local anesthetic is getting injected, you can see here. So bupropion 0.25% is injected 0.15 cc per kg at each site, and you can add dexmedetomidine to it. This is the maxillary artery which you see pulsating, and then you can you see the triangular shaped soft tissue, the pterygopalatine fossa, where you can inject. So this is the maxillary block. You have to give it bilateral. So coming to now problems because of airway sharing. Because the surgeon is operating inside the mouth, the endotracheal tube can get kinked, can get obstructed, the mouth gap will press the endotracheal tube. So how will you know the airway pressures will rise, the SpO2 might drop. The intubation, there can be endobronchial intubation because a lot of movement of head is there while the surgeon is adjusting the gap. So you must always confirm the position of the endotracheal tube before draping, and you are the endotracheal tube tip should be mid-tracheal, so that with the small flexion of the neck, it is not going endobronchial. Another problem is accidental extubation. So it is actually most feared, but it can happen. It has happened with me. So what can you do? You can keep calm. You have intubated. Remember, you have intubated this patient once, so you can intubate again. But most important is not remain focused on intubation, but most important is to ventilate this child. So how to ventilate? Now, intubation is difficult in this neck extended position. So you must ask the assistant to either hold the head or put a pillow under the head because it's an extended neck position. So make the head position neutral, stop nitrous oxide, do oral suction, and then remove the throat pack and remove the gag. Because if you remove the gag, again, it will be difficult for you to do suction and remove the pack. So in this sequence, you do it. Stop nitrous, do suction, remove throat pack, remove gag. And then you can ventilate even with oxygen if there is minimal bleeding in the mouth. Even if the child has some aspiration, remember most important is to oxygenate this patient. So you can ventilate with minimal, with less pressure, and then you intubate. So you can actually prevent the accidental extubation, and that you can do by sensitizing the surgeon. You can tell the surgeon how it can happen with his head movements. And so the surgeon, you can tell him all these deleterious side effects of this head movement and of the accidental extubation. So the surgeon can take care and take care so that the tube remains fixed. Now, excessive bleeding can occur, and as I have told, there is difficult to measure the blood loss. So the measures to reduce the blood loss, you can, what surgeon can do is local anesthetic with adrenaline infiltration. He can use tranexamic acid you are giving. Keeping an adequate depth of anesthesia is very important. Keeping it end-tidal CO2 concentration low is very important. Controlling the pulse rate, this you can do with dexmedetomidine, and avoiding hypervolemia. If you give a huge bolus of suppose 200 ml of fluid to this child who is weighing only 7 kgs, see, it will be too much for this blood. This 200 ml going to his blood volume will be too much for him. So this hypervolemia can increase the bleeding. So you must avoid hypervolemia. With all these measures, the blood loss will be reduced. Then a retained throat pack is another problem. So always confirm from the surgeon as well as assistant that with the removed throat pack. The dictum is the one who puts it will remove it. So if the surgeon has put it, he will remove and you will confirm. Ask 2 times surgeon as well as the assistant whether it is removed. Do a check laryngoscopy to suck out clots. But what happens? You can't do that deep laryngoscopy at the end, and sometimes the throat pack, if it is retained and directly pushed back, it can still be there and you can't see it on direct laryngoscopy. That can happen. So this retained throat pack is also included. I mean, the removal of throat pack is included in the surgical safety checklist of WHO. Now, another problem is post-extubation laryngospasm. There is, as it is, a respiratory obstruction can occur because of a swelling of airway, because the airway which is already compromised is a hypognatic patient, and you are closing that airway. The child who was breathing with that open cleft palate, and now the palate is closed. There is reduced space, and there is also swelling of that pharyngeal tissue as well as swelling of tongue because of the mouth gag. So all this leads to swelling of tissues in the pharynx, and this can lead to airway obstruction. So if it is a hypognatic child, sometimes you need to put a nasal or oral airway, a well lubricated one. If it is a pharyngeal flap surgery, then the surgeon only has to put the nasal airway because it can cause torrential bleeding if the flap is disturbed by your airway. And these nasal airways, what we get are very long. So you need to either cut them short or you need to do a check laryngoscopy and see where the tip of the nasal airway is. It should be just behind the uvula. It should be just visible behind the uvula, and the remaining airway you have to keep out. A lubricated oral soft silicone airways also are available. Those you can use. And a tongue stitch you can use, but it is uncomfortable for the patient. A patient who has, any patient who has a hypognathia, who can suspect a respiratory obstruction afterwards, after surgery, has to be monitored continuously in a high dependency unit, because anytime in the post-operative period, the patient can obstruct. Now the post-extubation laryngospasm. So it is common if the patient has a history of ERTI, and because of hyperreactive airways, it can be partial or complete. partial will use stridor, the complete will be silent and very dangerous. So remember, children desaturate very fast, and you see a saturation reading which is a few seconds old. So you need to take actions very fast. So the treatment is a CPAP with 100% oxygen. Even Xylocard, you can give 1 milligram per kg intravenous. It will reduce airway reactivity. And you can prevent it by extubating in deeper planes or extubating during inspiration. Pre-medication with Dexa also can prevent, is said to prevent the post-extubation laryngospasm. Now, emergence delirium can be a significant problem with the sevoflurane especially, and the incidence is very high. It's a morbidity for the child and very anxiety for the parents and caretakers and nurses. All the predisposing factors for emergence delirium are present in our cleft patients because they are less than 5 years, sevoflurane is used, head surgery, and pre-op anxiety of child and parents. All these are factors which are predisposing. And you can prevent an emergence delirium by giving a good pre-medication with midazolam, using propofol after you switch off sevoflurane, giving melatonin, and giving good post-operative analgesia. All this will reduce your emergence delirium and can prevent to some extent. So to conclude, anesthetizing small children for cleft lip and palate can be challenging for the non-experienced anesthesiologist. And so in pre-anesthesia checkup, you must look for the various syndromes, the cardiac anomalies, look for whether the intubation is difficult or not, look for URTI or a history of URTI. The cleft lip patients present unique problems like airway sharing with the surgeon. But you also share one important goal with the surgeon, and that is patient safety. So you have to do effective communication with the surgeon, and you have to work with the surgeon as a team. And this will solve the, this is the solution to this problem. You must work with the surgeon as a team, and continuously you must be watching the surgery, what state the surgery is going on. Now, the intubation as well as extubation is critical in this, and monitoring throughout the period for airway obstruction is important. You must have a plan for extubation as you are having a plan for intubation. The multimodal analgesia is essential for optimal recovery of this patient. And these are some of our happy patients. And I thank you for patient listening, and I am happy to take questions.
Thank you, Dr. Anita, madam. This was a wonderful presentation and a beautiful insight from you. All the videos were very mesmerizing, and it's really challenging to give anesthesia for a cleft lip, cleft palate, bachus especially with the syndromic, with cardiac issues, and with URTI, and with shared airways. And as you rightly said, you share the responsibility, and your surgeon also shares the responsibility. So you work as a team. So congratulations for the smile train as well. There are a few questions in the chat box. We'll just quickly take those. One is, what is the ideal age for reconstruction for the cleft lip and palate? Dr. Sarika wants to know.
The cleft lip, actually, you can reconstruct from age 3 months to 6 months.
Okay.
And cleft palate at 9 months.
Okay, that's great.
Palate at 9 months. The ideal age for cleft palate reconstruction is 9 months. And cleft lip is as early as possible, but 3 months to 6 months is the age. At Smile Train, they tell us to start at 6 because generally the children are poorly nourished, so their weight is very less in 3 months age. So we put them in nutritional programs. When they pick up their weight, then at 6 months we operate with the Smile Train, under Smile Train.
And that's it. And is it mandatory to do the chest X-ray for every kid having cough and fever?
No, actually, you can auscultate, and if you feel that a fever can be an upper respiratory infection. If you feel that child has lower respiratory infection, child has crepes and bronchi, then only you should do X-ray chest, because you should avoid exposing the child to X-rays unnecessarily. Anyway, fever and cough, you are postponing the case. So you don't need X-ray.
Yeah, exactly. There is a lot of secretion. If the secretion is copious, then probably you may postpone the case looking at the patient. And it should be a case-based, I guess, as you rightly said in your talk as well. And what is the lowest age and weight of the child where you use Dextromid? And do you have, how much maintenance dose do you use for such patients?
Dexmedetomidine.
Yeah, dexmedetomidine.
Dexmedetomidine, I use 0.5 microgram per kg up to 1 microgram per kg I use. And the smallest age it is actually used even in small children, even in neonates it is used, but it is off label.
Yeah.
But I am using patients who are 6 months age. I am using dexmedetomidine in almost all of my patients. 0.5 microgram per kg.
Any significant bradycardia did you notice while using dextromid, ma'am? Despite of giving a pre-medication?
No. Just dilute and give slowly. You can just give a bolus also, means slow IV bolus. It need not be infusion. So no significant bradycardia also.
Okay. And what dilution you prefer for a neonate or some 3 months baby or 12 months baby?
See, anyway, dexmedetomidine 1 cc we are diluting to 5 cc. So we are taking from that syringe bank. So when we take in our 2 cc syringe, suppose I want to take 10 micrograms, it will be half cc.
Right.
And that I dilute 2 to 3
times. Right.
So I make it half cc, 2, and then I inject.
Yeah. So more dilution is required so that you give a very titrated dose. Right.
Yes.
Okay. That's great.
Hello.
Yeah,
I have
please.
one question. I am Kamal Ladda from Akola. Madam, you are giving packs to each and every person, even if you are intubating with a cuff tube?
Yes, sir. I intubate with cuff tube, but those are micro cuff tubes. They are not our regular Portex cuff tubes.
Right.
The micro cuffs are very delicate, soft silicone cuff, and it's a short cuff. Like if you see a Portex, which is suppose 4 number Portex tube with a cuff, the cuff will be very elongated. And the problem with this elongated cuff is the proximal part of your cuff can be inside your vocal cords when you inflate. So the micro cuff tubes are designed in such way that the whole cuff is infraglottic. It is below the cord.
That's why you put the pack.
High volume.
Okay.
Yes, sir.
And one more question. You are pre-medicating on oral anxiolytic drugs.
Yes, sir.
Pre-medication. Have you ever tried for intravenous pre-medication?
Yes, sir. Intravenous, all patients I am giving, but oral will calm them before they come to you. Intravenous pre-medication also I give.
Okay. Thank you.
Parental separation from the parent and creating that anxiety that will be relieved by oral pre-medication. Am I right, ma'am?
Yes.
These children are very small. They hardly understand whether they are being separated or not. We always keep the parents beside before induction of the patient. And then we induce.
Parental presence in the induction room is very controversial.
Yeah,
because what I have seen, some of our parents of Smile Train, they are so they are not educated and low socioeconomic status, so they really don't understand what is happening. So in front of them, if you induce them on sevoflurane, press the mask on the child's face, they might take some other meaning from that. So it is everybody's preference. Not everybody likes to have a parental. I think it's more of a theoretical, or maybe in a very high socioeconomic or in foreign countries, they say the parental presence should be there in during induction. In our sort of places, I think parental presence is a hindrance.
Exactly.
And you want to make the child. So even if you are planning a sevoflurane, the child has to be calm, he has to be accepting the mask. And even if you want to take an IV line and do intravenous induction, a calm child is always preferred. But if you are giving, your center must have a facility for monitoring these children. If you are giving them any sedation preoperative, you must monitor these children with a pulse oximeter, and a sister has to be standing there.
Right. Right. Thank
Otherwise, you
you
don't.
so much.
Don't have.
Thank you. Thank you so much. I hope there are no more questions and we can quickly go to our next speaker. And Dr. Poonam, can you
Yes.
please take over? Thank you, ma'am. Thank you, Anita, ma'am.
Yeah, good evening, everyone. At the outset, I would like to thank the office bearers of Meerut Sangli branch for inviting me for the webinar today. So after a very interesting talk from Anita Nehete, madam, let us move further, move to something which we do quite often in our day-to-day practice, which is burns. For that, I would like to invite Dr. Sayogita Naik, madam, who is going to throw some light on the anesthetic considerations of a patient who suffers from burn and is now posted for aesthetic surgery. So over to you, Naik madam. Sayogita Naik madam, please.
Just wait. Yeah?
Yes, yes, sure, ma'am.
Devashri? Devashri? Okay.
Nehete ma'am, are you here? Till then, we can take few questions until madam is arranging for her presentation. Are you still here, ma'am? Okay, madam has started.
And video. Good evening. Hello.
Yes, ma'am, you are audible.
Am I audible? Yes. Good evening and thank you, ISM Meerut Sangli. Thank you, Rupali, Dr. Vasudha madam, and Rupali team. Okay. So the topic is the anesthesia consideration in chronic burn patient posted for aesthetic surgery. Slide. Oh my God. So burn, we define the burn as a wound caused by exogenous agent leading to coagulative necrosis of the tissue. And the etiology for the burns are thermal burns, moist heat, scald burn, that is more common in pediatric patient. Smoke and inhalational injury, chemical burns, acid and alkali, electrical burn, cold burn, and the radiation. So I am not discussing the acute burn situation, but the chronic burn situation. So we classify the burn depending on the thickness of skin involved, first degree burn, second degree, third degree burn, fourth degree, and the partial thickness burn and full thickness burn. So what is chronic burn? We can define as the second degree deep dermal and the full thickness burn after healing of the burn ulcer, causing contracture which restrict the movement of the affected part and, if untreated, progress to deformities. So today's major concern is these are the picture that shows the different type of the chronic burns, and this patient comes to for the reconstructive surgical procedures. So hand burn, upper extremity, lower extremity, neck contracture. So I would like to focus on the PBC neck. So because that is the challenge for the anesthetist for maintaining the airway. So neck contracture leading to fixed neck flexion and restricted neck movement. That result the kyphoscoliosis, lower lip seal, that result impaired vision, balance, and also difficult in swallowing, feeding, and speech, as well as there is the social stigma, depression, and the embarrassment. So the treatment for the post-burn anterior neck contracture is the contracture release and reconstruction with skin graft. So our role is to management of the airway, ventilation, and intubation. So it is the challenge to anesthetist. So expert anesthetist and the expert assistant should be present during time of the case. So we classify the PBC neck by Onaha's classification. Type 1, which is the mild contracture. Patient can flex the neck as well as extend away from the anatomical position up to 90 degree. Type 2 is the moderate contracture. Extension is less than 90 degree. And the type 3 is the severe anterior mentosternal contracture. The patient neck is contracted in a flex position and the chin and is occasionally restrained down to the anterior trunk. The patient is unable to reach the anatomical position of the neck and jaw. So that is the very serious situation or the for the management of the airway. So what are the problems associated with the PBC neck? There is the grossly restricted neck movement, restricted mouth opening and the narrowed nasal passages, difficult laryngoscopy and difficult mass ventilation too, compromised airway, psychiatric tendency in patient and possible drug interaction in anesthesia. There is poor hygiene, oral hygiene and the cervical spine distortion. So which point should we keep in mind during the pre-anesthesia checkup? That what is the type of surgery and the history part is also very important to know the time of burn and its duration. The cause of burn, is it electrical burn or it is the thermal burn, and the extent of the burn for the management of anesthesia. And assessment of the patient and the assessment of the neck airway is very important because neck fixed inflection, airway not accessible, limited mouth opening and need for positioning and repositioning, and also the vascular access is difficult if there is the scar tissue on upper extremity and the lower extremity. So we have to find out it. So once you assess the patient, taken the history, and then you have to investigate. And so many times these patients are the feeding problem, they are the malnutrition. So you have to optimize the patient by routine investigations, CBC, LFTs, RFTs, serum electrolytes, X-ray chest, and the ECG, and the special investigations, X-ray neck, AP lateral view. And if there is the third degree burn with restrictive lung abnormality, then you have to do the PFTs because the kyphoscoliosis restrictive lung abnormalities are there. ABG if required. 2D echo in the patient of the history of electrical burn is necessary. to rule out the conduction abnormalities. So these are the X-rays of this lady, 56-year-old female presenting with post-burn contracture with fixed neck inflection with a history of flame burn 7 years ago. So left side before the release and the right side is the after release, and the X-ray is showing small deformed nostrils and the acute flexion of the neck. So how to prepare the patient when he is posted for the neck contracture release? So first, psychological preparation is also very important. We have to explain the procedure day before or the day before the surgery, or when we plan for the surgery. We have to explain the type of anesthesia and the way method of intubation also, because the patient cooperation is very important. So many times in difficult airway situation, we do the maintain the airway by awake. We intubate the patient with the awake condition, in awake condition. So we have to explain all these things to the patient. We confirm the NBM. Also, the appropriate consent is important. Before day of surgery, prokinetics and antiemetics is necessary. So what are our plan? What should be our plan? So always keep the plan A, B, C, D, E. So plan A, awake nasal fiber optic or the oral fiber optic intubation, that is the gold standard. Or if not available or not possible, then the blind nasal procedure, that is also we should know, we should have the expertise in blind nasal procedure. Plan B, awake video laryngoscope if mouth opening is good, and the supraglottic airway devices in which we can use the intubating LMA and the supreme LMA, but mouth opening should be adequate. That time it is possible. But when there is the mouth opening is inadequate, that time the awake nasal fiber optic or the blind nasal procedure is preferred. Or if it is not possible with fiber optic or not availability and not expertise in blind nasal, then we have to release the scar under ketamine or the tumescent anesthesia before securing the airway. So, and last is the surgical intervention. So you have to keep all cricothyroidotomy tray and tracheostomy tray ready with surgeon. So how to prepare the patient when posted for the neck contracture release under the fiber optic intubation or the nasal intubation. So airway and the nasal mucosa with the nebulization with lignocaine and the adrenaline. We can use the nasal decongestant. You have to check the nasal patency and nasal passage by the soap patties. Lignocaine gargling we can use. In the OT, after preparation of the airway nasal mucosa, we take the patient inside the OT. That time we have to avoid the heavy sedation before securing the airway. And because our aim is to preserve the respiration, and the drugs which depress the respiration we have to avoid, or judicious use of, we can use the benzodiazepine and opioid. Iron glycopyrrolate is necessary, and dexmedetomidine for awake sedation with loading dose 1 microgram per kg for over 10 minutes we can use for the fiber optic intubation or the awake nasal intubation. So this is the trolley for the difficult airway trolley. We have to keep all things. So different sizes of the endotracheal tubes with stellate, with bougie, supraglottic airway, intubating LMA, and video laryngoscope, also McCoy, fiber optic scope, and also the cricothyroidotomy needle and tracheostomy. So all things should be kept before the procedure. So what is the blind nasal procedure? So nowadays, this procedure, we are not using this procedure frequently because we have the fiber optic intubation, but blind nasal intubation is sometimes useful. But for that, awake patient must be cooperate and respond to command. So adequate airway anesthesia by 4% lignocaine spray and by nebulization. So preparation of the patient, and at that time, just I told you, trained assistant who is familiar with the blind nasal intubation should be available. One anesthetic is not adequate when there is the difficult airway management. So assistant should be trained and ensure the patient is spontaneous breathing at all time. Once we have given the position, identify the suitable nostril and we insert the well lubricated 6 to 7 mm for the adult patient. This is for the adult patient. Diameter nasotracheal tubes, or in pediatric patient we can use the adequate size of the tube. And then this is the procedure how to intubate the patient by awake blind nasal technique. So I don't want to explain all these things, but once you reach at the glottic opening, there is the increased breath sounds and misting of the tube. So once the laryngeal inlet we noticed, then you have to ask patient to take deep inspiration, and in abduction position you intubate the patient, and after intubation you have to check your tube is in a trachea by confirming the breath sounds and the movement of reservoir bag once you connect it to the breathing system, and inability to phonate. And also the capnography is very important monitoring system to confirm the tube is in the trachea. Then after, once you confirm your tube is in trachea, induce the patient with suitable induction agent, mostly the IV propofol we are using, and then we inflate the cuff and secure the tube. This is the patient of the 12-year-old pediatric patient. So we intubated him with the awake nasal intubation, because fiber optic scope is not allowed less than the 7 mm internal diameter endotracheal tube. We didn't have the FOB for the pediatric patient. So we intubated the patient awake nasal technique. When we plan for the fiber optic nasal intubation, so preparation of the patient is same as as explained previously. So add TSP. So just revise adequate explanation of the need of procedure. You have to explain to the patient. Decongestion, drying secretion by using glycopyrrolated, and topicalization of the upper airway by nebulization, sedation, and the pre-oxygenation and the peri-oxygenation. So if possible, so many times in the contracture neck situation, patient, it is difficult to find out the landmarks to block the nerves. But if possible, when it is possible, you can block the nerves for the airway anesthesia. So these are the nerve supply, just inferior ethmoidal, for the nasal mucosa, infraorbital nerve, lingual nerve, glossopharyngeal nerve, main important is the superior laryngeal nerve we block that supplies the epiglottis and the part of larynx above the vocal cord, and the recurrent laryngeal nerve, that part of the larynx below the vocal cords. When the landmarks are possible, that time we can use these nerve blocks. So when mouth opening is adequate and planned for the oral fiber optic intubation, then we can block the glossopharyngeal by injecting the drug at the base of palatoglossal arch. Superior laryngeal nerve. So this is the method how to block the superior laryngeal in patient is in supine position with neck extension. Hyoid bone is displaced laterally. Palpate the hyoid bone, and bilaterally we inject at the greater lateral to the greater cornu. 2 to 3 ml of the drug we can use bilaterally, and so we can block the superior laryngeal nerve. So this is the internal approach to block the superior laryngeal nerve. Recurrent laryngeal nerve, we inject the local anesthetic drug in a trachea, translaryngel block or transtracheal block, we call it. Cricothyroid membrane we palpate and inject the drug. After injection, there is the cuffing. So it disperses the vocal anesthetic and block the recurrent laryngeal nerve. The other method is this say-go method, spray as you go method. When you are using, it is not possible to block the nerves, then we can use this technique. When you are doing the fiber optic, you can inject the drug local anesthetic through the port, injecting port of the fiber optic scope. So this is the patient with the neck contracture, limited neck extension is there. So our plan was with the fiber optic intubation, with the fiber optic technique, we intubated this lady. So it is a teamwork. Shall I show this video?
Yes, madam, show the video.
Where is the? It's okay. Okay, but we succeed to intubate in first attempt for this lady. So when mouth opening is inadequate and neck extension is inadequate, the gold standard is the awake fiber optic or awake nasal intubation. And if mouth airway mouth opening is adequate, then we can use the video laryngoscope or the supraglottic airway devices for the intubation purpose. So it is the flow chart for the difficult airway algorithm. So everyone knows about it. We have to try first the awake intubation, but if possible, then under direct video laryngoscope or the laryngoscope, we intubate the patient. But if it is not possible, then at least mass ventilation should be possible. If it is not, then we can use the supraglottic airway devices. And if it is also not possible, then call for help and for the emergency surgical intervention we have to do. So this is the algorithm how to go. DAS difficult intubation guidelines This is the laryngoscope and the supraglottic airway. If it is not face mask ventilation, and the cricothyroidotomy, just highlight. So after the fiber optic and the nasal intubation and the using supraglottic and the video laryngoscope, if video laryngoscope or the fiber optic is not available, not possible, then we have to, this is the other method how to release the contracture. So we can release the contracture under ketamine or the tumescent anesthesia before management of the airway. So we use the ketamine with IM or the IV. When we are using the IM, it dose is the 2 to 5 milligram per kg, or IV dose 1 to 2 milligram per kg, and with sedatives, benzodiazepines, and the glycopyrrolate, we can release the contracture with ketamine alone or with the tumescent anesthesia. So what is tumescent local anesthesia? So tumescent is the tumid is the firm and the Solon. So we injecting the large volume of the local anesthetic in combination with epinephrine. The total dose ranging from the range is the 35 to 55 milligram per kg. But that much of the volume we are using for the liposuctioning procedure, not for the neck contracture release. For the neck contracture release, we required hardly 150 to 200 ml of the volume. So that volume we inject subcutaneously or in a scar tissue. It is very difficult to inject the drugs in the scar tissue also. But this is the one of the method. So advantage of the tumescent local anesthesia is the hydrodissection of the tissue, easy disperse ability into the scar tissue, painless injection, and the good anesthesia, less bleeding, and the good post-op analgesia it's provide. So how to prepare the solution? Clean solution formula is there, in which 1 liter of the normal saline, in which we add the 50 ml of the 1% lignocaine with the 1 ml of the 1:1000 adrenaline, and 12.5 ml of the 8.4 sodium soda bicarb. So this is the method of the preparation of the solution. Disadvantage: high plasma level of the lidocaine reach after discharge, high fluid volumes, potential pulmonary and the cardiac problem, potential seroma formation, prolonged edema, and prolonged drainage. And this possibility is more with the liposuctioning procedure, where the large volume get used. So after the tumescent under the tumescent anesthesia release of the band, we can intubate the patient by routine ways. Succinylcholine we have to avoid as far as possible, but we can use in difficult situation because it is the chronic burn. After 1 year, after 2 years, we can use the succinylcholine. And the non-depolarizing muscle relaxants, there is the upgradation of the ACH receptor with altered protein bindings, and there is increased resistance to NMDA, hence required the large doses of the non-depolarizing muscle relaxant. And onset is also longer time, but duration is shorter. But even though when it is possible, we have to use the non-depolarizing muscle relaxant. So useful tip: consider superior laryngeal nerve block. If hyoid and the upper margin of the thyroid cartilage visible, it reduces the incidence of laryngoscopy. We have to fix endotracheal tube to the maxilla. Surgeon should always be present during the induction in case of surgical airway access is needed. Pain management: the local infiltration and the regional block, superior cervical plexus block is considered. That is helpful. And the systemic multimodal analgesia we can use by using IV paracetamol, tramadol, etc. So, like the intubation, extubation step is also very important. So extubation, you do the extubation when patient should be fully awake, conscious, oriented, muscle tone and the power adequate, maintaining tidal volume and the saturation, oxygen saturation. We can extubate the patient, but if it is not possible, then we have to keep the tube and we can monitor the patient in the ICU, or we have to wait for the extubation. So this is the DAS extubation guideline. So in Sassoon General Hospital, this is the statistic. In Jan, 9 PBC neck surgery we did, and the other PBC surgeries are 27, 23, 8, and the 22. And till date, Jan 2024 to till date, 5 PBC neck surgery we have done with 13. Other surgeries are, if airway problem is not there, then we can do as a routine surgical procedure for the release of the contracture. Thank you.
Thank you, Sayogita Naik Madam, for the brilliant talk, and thank you so much for sharing the real-time pictures. It was very pictorial presentation. As of now, I do not see any questions in the chat box. So if I may add, Madam, is it not advisable to keep ultrasound in the armamentarium? Suppose the patient is having a grade 3 post-burn contracture. FONA may be really difficult. So do you suggest to just mark the cricothyroid membrane with the ultrasound? So if in case there is a difficulty in fiber optic intubation, and if we'll end up in a situation when we have to do a front of neck access, just identifying the membrane with an ultrasound may aid in the already difficult anatomy of such patients.
Yes, madam, we can do that USG guided identification of the landmark. But when it is possible, you have to use the USG guide, USG.
Correct, only if it is
But,
available.
huh?
Only if it is available, right?
Only it is in Sassoon Institute. There is the USG, but it is in the TICU, so we can't ship the USG machine. So if possible, we can use.
Thank you, madam. Your
USG
statistics
machine.
are also very good. You have done many patients. Thank you so much for sharing the slides and the real pictures with us. There are no questions at the moment. We will see if there are questions towards the end. Thank you so much.
Thank you.
We would now move further. I would like to call upon Dr. Gauri. Madam, is she here?
Yeah, I am here. I'm here now.
Hi, Gauri.
Hi.
We have a very young, dynamic colleague with us, Dr. Gauri, who has been introduced already in the beginning of the webinar. Over to you, Gauri. I think you're going to speak upon the reconstructive surgeries and the free flaps today, right?
Yes, I am. Please tell me if my screen is visible to everybody. Then I can go on slideshow mode.
Yeah. We can see your slides. Just check if they're moving.
Yeah, so I'm just going to check if they're moving, right? And then we can see. All right. A very good morning, a very good evening to all of you, and a very huge thanks to ISA Sangli Miras for actually having me on this webinar with such eminent speakers. I'm overwhelmed with the fact that I've been invited here. So, moving on to our topic, when we talk about anesthetic considerations for free flap surgeries, we look at a distinctively plastic surgery OT. So, if I were to ask you what you visualize when you look at a plastic surgery OT, I'd think of the really long hours that we put in, the absolute obstacle course that you have to go through when you have to reach the patient. potentially difficult airway if you're looking at head neck surgeries, which is a major bulk of the plastic reconstructive work that we do at Tata. Of course, not to mention the music because of the long hours. Most of the other theaters will not have it, but plastic surgeons have their music on, and it's a really nice OT to be in. So what exactly do we mean by a free flap? So it's a complex reconstructive procedure where one tissue is transferred from one part of the body to the other. So this is not anatomically continuous or congruous. So the entire thing, this is like various combinations of skin, fat, fascia, muscle, bone, tendon, nerves, whatever is required to fill the defect is moved along with its blood supply, and microanastomoses are carried out to ensure that the blood supply is patent. When you look at the reconstructive ladder, you'll see that the free flap falls right on top. What does that mean? It means that it requires there are multiple technical difficulties that could take place when the free flap is going on. It requires a lot of time. Resources required to manage and operate the free flap are quite a few. And the extent of post-intervention after recovery is also high. That is what puts it so much above in the reconstructive ladder. So when do surgeons choose to do a free flap? So this is a little bit like a puzzle. You have three components, you place them all together, and then the free flap comes through. First, you look at the clinical indication. Free flap is usually done for patients who have defects either because of trauma, burns, or due to a malignancy surgery where taking the primary tumor out is going to use a huge defect, which would lead to a malformation, an anatomical defect, which needs to be filled. Then you look at the surgical requirement because you also need to choose what kind of a flap or how this defect needs to be filled. So you look at the location of the defect, you look at the volume or the size of the flap that's required, and then you also look at what is the tolerable bulk. I'll come to that in a minute. And then you have this huge maze of the kind of flaps that could be carried out for any patient for any location. So if you have, let's look at the flaps for a minute later. Now, for instance, let's take a defect that is present on a patient's face. Supposing it's a small defect which is there on the patient's cheek, they're going to require a smaller graft. So when they're going to choose the flap itself, they will choose a flap with a smaller bulk. If, however, the entire jawline is going to go away and they're going to require bone for reconstruction, you're looking for something a little more robust that comes with a bone that would maybe be a free fibula. Just for a simple example of the wide variety of the flaps that are available, let's look at flaps that are available only for breast surgeries. Now, this is one of those areas that's clearly growing, and the demand is increasing even in a center such as ours, where patients are coming from really poor socioeconomic backgrounds, from really far corners of the country, where young women are choosing to conserve their breasts even after carcinomas. So you can have the free flap being achieved from the abdomen through the TRAM, DIP, SIEA, or from the back using the latissimus dorsi, which is very, very common. LD is the most common one used. Or you could have one from the thigh, from the gracilis, from the buttocks, or even the profunda artery perforator. So one of the objectives behind putting this slide, or actually showing you why you require, how many places the flap can be excised from, is to explain the extent and nature of plastic surgery. Let's take this woman who's come to us for a breast surgery. When the breast conservation is done, the tumor is out, and now now the plastic surgeons have to evaluate what is the bulk of the breast tissue available, how they're going to reconstruct it so it looks similar to the other one. So which is why they can't really come up with a concrete plan before. They can maybe tell you that, maybe we'll do a TRAM or maybe we'll do an LD, but then they have no way to know for sure until they've seen the defect which is actually created. Now, once they decide the defect and once they decide the flap, that's where your challenge begins. Because if they tell you that they're going to do a transverse rectus abdominis myocutaneous flap, you're brilliant, you're set. You've intubated the patient to begin with, and the flap will continue in supine position. If, however, your surgeon decides they want to do a latissimus dorsi flap, it means that for harvesting the flap, your patient's going to go in lateral position and the patient's going to become straight again. Now, this also means that every area of the patient is going to be scrubbed, and you're going to face a massive challenge with regards to placement of your ECG leads, placement of your probes for monitoring temperature, placement of your warming blankets, and everything. So the patient is going to be scrubbed. So we've had instances, we are an institute that sort of has patients that have come after very long periods of time for surgery, and the tumor grew in size. So initial plan was to do a smaller flap, and then it became, when the defect was excised, it was the patient come a lot later, so a larger flap was required. So we had scrubbed this woman from her chest right up to the ALT. So everything was scrubbed and cold. Then we had to do an LD, so we had to scrub her all over again in lateral position, which meant that we had little or no space to warm her up. Now, this brings me to my perioperative concerns, which is also something that we would worry about if a patient was coming to us for free flap surgery, which would be in evaluation. So when you're evaluating a patient for pre-flap surgery, you're going to look at baseline investigation. So your CBC, RFT, LFT, serum electrolytes are a given. Then you look at the patient's comorbidities, and then you decide if you want additional investigations such as the ECG or chest X-ray, depending on what age group they fit in. Because whether it is for breast surgeries or for traumas or for oral malignancies also, sometimes you have really young patients coming in for surgery. So the entire spectrum of investigations may not always be necessary. You need to take a thorough history because they could have comorbidities that require optimization, investigation, and appropriate workup, particularly for coronary artery disease, diabetes, and hypertension. Pediatrics is a special group of patients who, when you're doing free flaps for, you need to evaluate them quickly because this is the first time they're coming to the hospital a lot of times. So if they have unevaluated conditions, congenital conditions, you really don't know about them. Smoking cessation is a must. We will come to it in my next slide. But because of that, you need to have a thorough history of not only if they smoke, when was the last time they smoked? Because a lot of times patients will come to you and say, we have a lot of these head neck malignancies. So we have a lot of them who are smoking, chewing tobacco, etc. You ask them, "Kab last cigarette kab piya?" "Chhod diya abhi, chhod diya." When you ask them in detail, "Kab choda?" "2 din pehle choda." So that sort of doesn't work for us at a PAC level. So this is an intervention that has to be done when the patient comes to the hospital for the very, very first time. Then you look at the clinical evaluation. Airway evaluation is a must, whether the patient is coming to you for a free flap surgery or any other surgery. But with head neck malignancies, you could have difficulty in intubation because of the deformity that is created by the tumor. Or if this is a free flap for correction of a burn defect, then the deformity could exist on the face simply because of the burns, the face and the neck. You also need to look into things like anemia and nutrition correction because the patients could have malnutrition either from malignancy or just in general a poor habitus, which a lot of the poor patients in our country do have. Then coming to the most important, there are the 3 C's. One is conversation, consent, and counseling. Why I've put them or highlighted them is because our free flap patients are so special. They're not really aware when they come to us about the massive enterprise that they're about to take up when they say, let's do a free flap. The onus is on us as an anesthetist to explain to them the course of the perioperative procedure, to explain what to anticipate through recovery, to take a proper consent and counsel them. This is particularly important in patients who have a difficult airway, in patients whom you're intending to put in a nasotracheal tube, maybe leave it in overnight, maybe ventilate them, or even do a tracheostomy. So whether your surgeon has counseled them or not, you need to have these patients counseled so that you have a smoother perioperative course. Informed consent at this point is vital, particularly if you want to do an awake fiber optic intubation or you have a difficult airway that you are anticipating any loss. So what does the evidence say about this optimization? What are the key factors? I'd highlighted them in red before. So for smoking and tobacco cessation, the period that needs to be elapsed is 4 to 6 weeks. So am I saying that if a patient, when our patients come to us for head neck malignancy in the PAC, we say now stop smoking and come to us 6 weeks later? No, because like I said, all of these interventions that are there on the screen currently have to be done as a joint decision between the surgical and anesthetic teams. So the first time the patient visits the hospital, till the time the surgery is planned, all of these interventions must happen in order to ensure flap survival, right? So if the tobacco cessation or smoking cessation does not happen, you're going to have an increased sympathetic response, increased vasoconstrictive response to everything while that nicotine is still in the body. With patients who are hypertensive and poorly controlled, there is a shift to right for the home or for the internal milieu, which means that the flaps will be perfused at much higher pressures, which is really bad for us because that means that through the surgery, the patient is going to bleed quite a bit. And if through anesthesia, the patient becomes normotensive for other patients, it means that the flap will not perfuse, so there are higher chances of flap loss and re-exploration. What about diabetes? Diabetes is going to lead to autonomic changes among the local vasculature and generalized autonomic changes as well. It means that these patients will not respond too well to the hemodynamic changes that occur through the surgery. So you need to target HbA1c levels of less than 8. For anemia, your trigger is 8 gram %. So am I saying we transfuse at 8 gram %? What I'm saying is that we correct anemia at 8 gram % using injection iron. We use ferric carboxymaltose as a combination with methylcobalamin and folic acid to ensure that the patient has a better chance of recovering. Now, here, you're torn because your oxygen delivery is going to be compromised if your hemoglobin is too low. And there's going to be an alteration in the blood rheology and morphology of the RBCs. There are going to be too many RBCs. Viscosity will increase if the HB is too high. So you need to strike a balance. So this is where your IV iron comes in, because you know that it will kick in about 10 days after injection. So what it means is by the time the patient is ready to recover, the patient is naturally producing more RBCs and they're doing a better job of maintaining a better hemoglobin. And the thresholds are, your transfusion thresholds can be held. Now, next we come to the last, but absolutely the most important factor in optimizing your patient, which is nutrition. Most of our patients who come to us are malnourished, whether they come for cancer surgeries, for reconstructive surgeries. We live in a country that has a lot of poorly nourished patients whose protein intakes in general are also very poor. Let's leave aside the possibility that they have an oral malignancy for a minute. Even if they don't have an oral malignancy, our country tends to be a generally carbohydrate-laden country, so the diets are carbohydrate-rich. So this is where we intervene because we know that a decreased protein intake or lower protein levels can lead to a state of catabolism and impaired healing. What this malnutrition and decreased protein intake is also going to do is going to ensure that there is absolutely no muscle bulk for reconstruction. We've actually seen that happen where an ALT flap was planned for a particular patient. Patient defaulted, came 3 months later, was even more poorly nourished. There was absolutely no bulk in the ALT to close the defect that they had planned for a buccal mucosa flap. So what do we do to them? You send them to a nutritionist. You can send them to a clinical nutritionist to optimize the protein intake, to optimize other nutritional intake. So we're not talking only protein powders. You balance the diet out. You help them make better choices with their diet. And in addition, you start them off on exercise. So you build the muscles that your surgeons would require for reconstruction. This also helps you because patient is in a better functional state when they come on table. So they're going to heal better, even from your anesthetic. So what are your targets for anesthesia when the patient comes on table? First, you need to prevent wound site infection. You definitely do not want these patients coming back with surgical site infections and you having to re-explore them. You need to prevent medical complications such as thromboembolism because patients undergoing free flaps such as free fibula are going to be immobilized for a period of say 7 or 8 days, where after that they're going to be made to stand up. These are major surgeries, so the potential for TVT exists and you don't want that to happen. You want to avoid sympathetic nervous system related vasoconstriction, and you want to ensure good flap perfusion with excellent oxygen delivery to ensure that all of this hard work that you and the surgical colleagues have put into putting this flap in place does not go waste. So how do you induce these patients? So to be extremely honest, the induction should not be very different from what you normally do if your airway is not difficult. You will simply tailor it to the patient. For instance, if you have a patient with a coronary artery disease, you might want to consider using etomidate. But otherwise, by and large, propofol is going to be your drug of choice. Why I have not even included using purely regional anesthesia is because free flaps are inherently long surgeries. So even in the fastest of hands, from the excision of the primary defect to harvesting the flap and insetting it. Or if there is no malignancy, to simply harvest the flap and to put the flap back in, complete your anastomosis, and then extubate the patient, you're looking at a period of say 3 to 5 hours. This period to have a patient who's completely immobile is very tough. Not impossible. There are patients who we have done in combined spinal epidural as well because the defect was in the limb, lower limb, but it's not as comfortable as having the patient under general anesthesia because you have a better control over hemodynamics and hence over flap circulation. You need to take into consideration the fact that the patient could have a difficult airway. I thank Dr. Sayongita madam from the bottom of my heart for doing such an exhaustive job of explaining difficult airway algorithms. So I don't have to go over all of them again. But please remember that in any case of any difficulty, you have your difficult airway cart at hand, ensure you have apneic oxygenation, and you have trained help at hand who could come whenever you need them to. Now, the next question that usually arises is, should we use inhalationals or should we use TIVA? Like, what is the better choice? So one could argue on either lines. If you're using inhalational agents, they do have their own advantages, which is that isoflurane will help you attenuate ischemic reperfusion injury. Sevoflurane will help you maintain microcirculation. On the other hand, TIVA is a brilliant choice because it will reduce stress-induced vasoconstriction. It will reduce post-operative nausea, vomiting, produce a smoother recovery profile. So which one am I recommending that you use? I'm saying we look at the patient. Let's assume this is a patient I want to extubate on table. I definitely do not want this patient puking, coughing, retching, vomiting, all with that flap, those blood pressures moving up and down. So if this patient was going to be extubated on table, I would definitely consider TIVA. If, however, I plan to keep them intubated overnight, then most of these concerns are attenuated on the whole, and then you can safely use inhalational as well. What about our intraoperative concerns? First and foremost, like we spoke before, thromboprophylaxis has to be our chief area of concerns. Patients, so this is one of those places, one of those rare places where you will see that low molecular weight heparin is placed on a stand which is slightly lower than DVT stockings and pneumatic compression devices. And why is that? This is because there is a bleeding risk with low molecular weight heparin. There is also a risk of flap loss. We will come to that a little bit later. So here but can we leave these patients without thromboprophylaxis? Absolutely not, because there is a possibility of immobilization, not just because they've undergone major surgery. It is also because they want the flap to heal. So they don't want the flap to move too much in the first 24 odd hours. So here we use DVT stockings, we use pneumatic compression devices, depending on the area of your interest. And low molecular weight heparin in low doses as a prophylaxis can be given for DVT. But high doses of low molecular weight heparin are not encouraged. Antibiotic prophylaxis has to be given less than 60 minutes before induction. You need to have extensions and connections at hand. Whenever you go to a plastic surgery OT, you will find that the patient is under the microscope and you are really far away from them. So your circuit needs to be long. Your IV connections need to be long. Your ECG cables, BP, all of that is going to be really far away and really long. So you need to have those available. What do we do about monitoring? You need to have ASA standard monitoring. Now, depending on the nature of the primary surgery, if you're anticipating a lot of loss, arterial line, central venous catheterization, or even cardiac output monitoring if your patient has heart disease or any such conditions that predispose them to cardiac failure, cardiac output monitoring can be used. Make sure that you have long cables. I'm going to reiterate, I'm reiterating this again and again because this is unfortunately very common. Every time we change the position of the patients, all of our monitors fall off. Every time we move the patient, the monitors follow. It's very, very unfortunate, but when these connections are made, we also reiterate or emphasize on checking the connections to ensure that the connections are not loose. For instance, we take an IV line in the left dorsal and we hand the patient over to the surgeons. After a while, you're injecting. 3 hours later, you realize the patient is just not going under. You open all of those drapes, you swim across, you move through the obstacle course, finally reach the patient, open the drapes to find that your IV line had gotten disconnected long ago, and you have been happily watering the field drapes. This is a major, major problem. So because you have so many extensions and so many connections, you have to ensure that all of them are in place every time you change the patient's position. You need to be very careful about positioning the patients. You pad the pressure points. Avoid any unphysiological positions that could be given. Straps are necessary because patients should not fall off, particularly when they're in lateral position, prone position, or anything of that sort. Regular assessment is necessary to ensure that the leg has not fallen off, the hand has not fallen off. This is particularly because there are so many drapes through the plastic surgical procedure. Like the entire patient will be draped because their area of interest will be in one part of the body and the area of harvest will be in another. So your entire patient is going to be scrubbed and draped. You will have no access to the patient. Most importantly, you need to watch for the hands. What do I mean when I say watch for the hands? This is particularly true in head, neck, and breast because the surgeon is using the retractor and that hand is coming here. It's going to cause a kink on your tube. It's going to cause disconnections if you're not vigilant. So you need to watch the surgeon's hands. You need to keep a watch over your airway pressures to ensure that your patient is safe. How do you ventilate this patient? It seems like a no-brainer, honestly. Obviously, normoxia and normocapnia is the way to go. And this is what you would want for every patient. But why are we emphasizing? Is because hypoxia can cause catecholamine release and vasoconstriction. Hypocapnia will also cause vasoconstriction, and hypercapnia will cause acidemia, reduce the RBC deformability, and lead to catecholamine release. What is the analgesia of choice? So you have to remember that the analgesia is from the primary resection or the donor side. The flap itself is denervated. So you need to use the multimodal analgesic approach with minimal opioid use. Is there a role for regional anesthesia? Yes, there is a role for regional anesthesia, but the role for regional anesthesia remains rather limited. It will remain limited to the intraoperative period. But you have to remember that our patient is not going to be in a state to be able to communicate with you. If you have a surgery that is congruous with any sort of regional anesthesia that you could provide, you should consider giving. Like for instance, if this is a breast surgery that you know is going to be painful, you could use paravertebral catheters, or you could consider the ESP block. But by and large, the WHO pain ladder should suffice. Why should the role of opioids be limited? Is because, and when I say why should the role of opioids be limited, I'm not talking about the intraoperative use. You can use intraoperative opioids as you like it, as you see is clinically fit. What is important is the post-operative use. Why should you limit it? Because intraoperative opioids do lead to some amount of vasodilatation and anti-inflammatory effects. They lead to PONV, which could lead to retching, which is a problem. And we find that with OFRA, there is a vasodilatory and anti-inflammatory effect to the other drugs that are used. We also find that a large use of opioid-based anesthesia in the intraoperative period leads to a large amount of fluids being used and large incidences of flap thrombosis, which is why maybe sparing the opioids is a good idea in this case. What about dexmedetomidine? Is a good drug to be used? We find that dexmedetomidine is an excellent drug to be used in the intraoperative period, particularly when sympathetic stimulation is high, so that you want the blood pressures to be controlled, no extra bleeding. You want the flap to be as is. In the postoperative period, however, the analgesia would be excellent from the drug. However, there's a potential for hypotension, which may not be so desirable. Does chronic pain occur in patients with free flap? Yes, it does. And the incidence is somewhere around 10 to 15%, depending on the area of excision. So this is going to happen in the native area, with the donor area of the flap. That's what's going to have the pain. The pain can be deformative, right? It's going to be crippling for the patient. It could be a burning type of pain that actually requires lignocaine injections, lignocaine patches, or it could simply be this dull aching pain that occurs from a tissue where the muscle has been excised. So if we want to prevent this chronic pain in these patients, then acute pain has to be handled in the postoperative period to ensure that this does not. Just one second. My slide is not reaching. Okay. So what about emergence and extubation? When you're extubating a patient, like with most of these procedures, you need to have a team consult. You need to have a chat with the surgeon to ask them if they need, how immobile do they need the flap to be? Is there a possibility of re-exploration? How bulky is the flap? Is it going to have an impact on the airway? Because all of us understand that when and a flap is going to be inserted immediately on the face or on the neck or anything of that sort, there's going to be increased edema. If there's increased edema because of the insetting of the flap, and there's going to be an inflammatory response at that point, there's a likelihood that your already difficult airway will become even more difficult. Another thing that needs to be considered is institutional protocols. Why is that important? If your center doesn't do too many free flaps, this is maybe not a very usual occurrence for you, then your post-anesthesia care unit is not going to be very trained in managing a patient who is awake and possibly intubated with the free flap in place. In such circumstances, it would not be unwise to consider the use of a ventilator for one night to let the edema settle and defer extubation till the next day. However, if your center, like ours, does a large volume of airway cases, our nursing staff, our post-anesthesia care unit is geared up and is very habituated to having these patients. So what do? We leave the nasotracheal tubes, even with the large airway defects or with the large bulky flaps on the face. If the patient has a nasotracheal intubation and the surgeon has chosen not to do a tracheostomy, we will leave the nasotracheal tube in situ and leave the patient spontaneously breathing. They will have a T-piece to supplement oxygen from, and that's about it. But key here would be vigilance on the part of the post-anesthesia care unit, because we will have to see if the patient is breathing okay, the depth of respiration is okay, if there are any signs and symptoms of tube blockage at all, because this patient will not be able to talk. So after taking into consideration all of these things, you have to decide whether or not you're going to extubate on table. If you're not going to extubate on table, you're going to leave the tube inside. Are you going to use a ventilator or not? These are decisions that have to be had with the surgical team together. Whenever you do decide to extubate, the patient needs to be awake, cooperative, but there should be no BP surge. So given this picture, it's very clear that extubating such patients is not easy. What makes it easier is having an excellent preoperative counseling. So if you're going to leave a nasotracheal tube overnight, you need to have explained this to the patient one night before, when they come to you, that there will be a tube, you will not be able to talk. This is a temporary situation. You need to write and tell us what it is. You need to sign and tell us what it is. You will be able to communicate, just not verbally. When you do extubate, make sure you have an airway exchange catheter or bougie at hand. Surges in blood pressure are not welcome, so lignocaine or esmolol should be available. You have to be ready to intubate or tracheostomize the patient at that point of time if you find that they are not able to maintain the airway. So what is the institutional protocol at Tata? It is to have the head neck surgeons available on rounds at that point of time when we extubate such patients in the post-operative period, particularly those in which we predict difficult extubation. If you remember, Sanyogita ma'am has just shared the guidelines for difficult extubation. So you identify these patients, you make sure your surgeons and all are ready, use an airway exchange catheter or bougie, extubate over them, and then watch the patient vigilantly till you are sure that they can maintain the air. So what are your goals in the post-operative period? You need to maintain normothermia. Hypothermia is going to lead to vasoconstriction. So basically, vasoconstriction is a very, very, very bad idea, intra or post, right? You need to create a situation where there is hyperdynamic circulation with high cardiac output, low systemic vascular resistance. Blood pressure has to be normal for the patient. If for some reason you have taken up a hypertensive patient, 120/80 is not your blood pressure to go. You need to check the sleeping blood pressure for that patient, what it has been, and maintain the map according to that. You need the hematocrit at around 30%. You need to check hematocrit for every 6 hours for the first 24 hours. This is particularly where you're worried that the patient is going to bleed through their drains. So any lower the hematocrit, the oxygen delivery is impacted. Any higher and your viscosity is gone. Urine output has to be maintained at 1 ml per more than 1 ml per kg per hour in the postoperative period to sort of be a surrogate marker for flap perfusion. This will also help you wash out the lactates. Your SpO2 should be more than 94%. The flap has to be inspected regularly. So the most common and the most effective, most cost-efficient way to do it is to prick the flap. So the first time I saw somebody pricking the flap, I was appalled at the number of pricks there were. And this was in my residency. And I actually went and asked them, patient ko to dard ho raha hoga. This is before I realized that there is denervated flap. But when you prick the patient and you have a good bleed, you know that the flap perfusion is through and it's happening well. Do you have other alternatives that may be better than clinical judgment of is this a good drop or can the bleed be better? Yes, you do have Dopplers, radio-labeled microspheres, and erythrocyte dermofluorometry, and a lot of complicated other words also. But the most effective, cost-efficient, and clinically used, widely used, is the prick. Simple pin pricks on the flap side to see the bleed. So, why are we talking about these flaps? Can we impact the flap survival? Yes, we can. Let's just look at the properties of what a new flap is like. Like I said, they are denervated. So they don't feel pain over the side of the flap. But that does not mean that this new vasculature doesn't respond to chemical and physical stimuli. So if there are lactates in the milieu over there, they are going to respond by vasodilatation. If there is noradrenaline, it is going to vasoconstrict. Blood flow normalizes to the preoperative blood flow only 3 to 4 weeks after. Till then, it is much lower, which means that your flap perfusion is highly dependent on the blood pressures you maintain. The lymphatic drainage is not restored after flap surgeries, which means that any extra fluid that you give will only stay there as interstitial edema and the body has no way to clear it. Can anesthesia impact flap failure? Yes, this is the Hagen-Poiseuille equation. So the most important factors to be looked at is the delta P, which is the pressure difference between the two tubes. Now, if I was to create a pressure gradient, my physics was really poor, which is why, honestly, I chose medicine, but apparently you have to look at this in anesthesia as well. So let's just go over the basics as much as I have understood this. So blood pressure gradient between the artery and the vein. This is the delta P. So the larger the delta P, meaning larger the pressure gradient between the artery and the vein, better the flow will be. What does that translate to? Higher the blood pressure, higher the flow. But is that really a good thing? It's not, because higher the blood pressure, there's higher the extravasation also. Now, this is if I was to single out one single factor out of all of these things that makes a difference to flap survival, that would be the R, or that is the vessel diameter. Now, if you look carefully in the formula, it is the fourth power of R. So if there is any amount of vasoconstriction, it will severely reduce perfusion, meaning wider the blood vessel, obviously better perfuse the area is. So if our blood vessel was 10 centimeters wide, just as an example, blood flow would be 10 raised to 4. If it became, say, 5 centimeters, it would only be 5 raised to 4. So there would be a huge mismatch by simply halving the diameter, which essentially means that severe vasoconstriction is very, very bad for these blood vessels. What about the viscosity of the blood? The more the viscosity, the lesser is the blood flow, which is why we have that target of hematocrit between 30 and 40. What about the length of the vessel? So the longer the vessel that is used for anastomosis, the lesser is your flow. So what are the dilemmas that come up in clinical practice for flaps? I'll just go over them quickly once. So should we use fluid therapy that is restrictive or liberal? So we obviously use balanced salt solutions and colloids and blood products as required. But because we want a hyperdynamic circulation with high cardiac output, peripheral vasodilatation, large pulse pressure, we might be tempted to give more fluids to create this more flow across the flap. But if you increase the fluids, you will increase the complications because the fluid will seep into the interstitium. But if you restrict the fluids, you run the risk of hypotension and flap compromise. So what is our solution? Hole-directed fluid therapy. If you're going to put in an art line, make sure that the stroke volume variation is less than 13%. Your urine output as a surrogate marker works pretty well here. So urine output more than 0.5 ml per kg per hour. And you can check the serum lactates to ensure that they are not too high. Are vasopressors good or bad? So there's a changing paradigm here. There are potential complications with use of vasopressors, which up to 5-6 years ago, we used to be trained to not use vasopressors because they could lead to complications such as thrombosis, vasospasm, and reduced blood supply because of vasoconstriction, correct? But these vasopressors are the ones that are allowing us to have adequate hemodynamic control without using excessive fluid, without allowing, and particularly when the cause of your hypotension is vasodilatation from the anesthetic. So what does our current evidence say? So there's a really nice systematic review that was written in 2019 in the Journal of Reconstructive Microsurgery that says that vasopressors do not adversely impact the flap survival. So we don't really have evidence to say that if you use noradrenaline, it is good for the flap, or if you use adrenaline, it is good for the flap. But what we do know is that the use of either of the two is not going to have an adverse impact on the flap. When it is necessary, you must definitely use vasopressors. Vasopressor of choice will be noradrenaline because adrenaline will lead to a lot of anaerobic metabolism, a lot of lactate generation. So what is our solution? We target the MAC carefully. We assess the cause of hypotension. So if it is because of vasodilatation, we'll treat it with inotropes. If it is because of simply a loss of circulating volume, then we treat the hypovolemia as is required. Now, this is just an example about why these two things seem so complicated. So this is your new vessel, and this is the artery, vein, and graft. So if I increase the blood pressure, or if I want to increase the flow across these newly formed vessels, I'm going to increase the blood pressure. When I increase the blood pressure, the perfusion across the membranes will happen. And here you will have a lot of tissue edema. Now, this tissue edema, along with this new bulky flap, will create an added tension around the vessels, which will not allow them to expand. In addition to that, if you have vasoconstriction because of any reason possible, additionally, this is going to impact your flow. So you're in a really tricky place because you don't want to cause vasoconstriction. However, you want the blood to not be too viscous. You want to still maintain the flow and still have a good blood pressure. So this is slightly tricky, or to be honest, very, very tricky. Is there a role for tranexamic acid? So tranexamic acid, by and large, I would think is a magic drug with regards to particularly with its use in trauma. And given the fact that you are going to either create trauma while taking the primary out, or when you even remove the free flap from its native site, it seems to be something that could be used. However, there's a fear of thrombosis. And, if I use tranexamic acid, what if there is additional risk of thrombosis and then my flap dies? But when you look at literature, there's flimsy evidence on either side. So we don't have proof to say that it will cause thrombosis. However, we don't have very robust data to suggest that it won't cause thrombosis either. It has been used by a large number of people. Progressively people keep publishing data on the use of tranexamic acid, but like you can see, most of it is retrospective in origin.
Dr. Gauri?
So the current,
So sorry
yes?
to interrupt in the beautiful lecture of yours. We are running little short of time. Could we just skip on a few slides? And
Sure. I'm almost done.
Yes, thank you.
Yeah, I'm almost done. So the solution would be to tailor to case requirements. Is there a role for heparin? Low dose, yes. If you think the patient's going to not be ambulated, low dose for preventing thromboembolism is brilliant. High dose, there's a likelihood of post-op bleed, flap loss with an odds ratio of 7.8, which means your patient is 7 times more likely to have a flap loss if you have high dose of heparin. But if your patient has been re-explored multiple number of times because of flap failures, please assess the cause for flap loss. If thrombosis is the cause for flap loss, you can start a heparin infusion with APTT monitoring and do this for 24 to 48 hours to ensure better flap survival. There are multiple reasons why flaps fail, as can be seen in the table. The incidence is variable from 0.5 to 10% because there are various kinds of flaps and their What we need to remember is that the salvage rate is nearly 75% if they are managed in a timely manner. What is the relevance for us? Early detection is early exploration. So flap failures are definitely emergencies that need to be taken on the table as soon as possible. When the flap review is being done, your airway is already compromised. You need to review your lab investigation because the patient has already undergone a prolonged free flap surgery. You need to assess if blood is required, and need for post-op anticoagulation has already been established. What are our key takeaways from this? For me, they are that the PRS reconstructions seem like an easy job because they're very long surgeries where you're not really actively doing anything, unlike say major GI surgery where you're on your toes and doing something or the other. Unfortunately, the data that we have is evolving and is emerging, so we are not very sure about what the right approach is to ensure flap survival. There are increasing indications and ever expanding flaps, which means that we need to keep our knowledge updated with regards to those. We need to remember that balance is key with regards to drugs or fluids. Vigilance is mandatory for the flap failure. And communication with the surgical team is an absolute prerequisite. I thank you for this lovely opportunity, and I hope you have these stages of anesthesia uninterrupted by anything. Thank you.
Thank you. Thank you so much, Gauri, for an excellent talk. I'm really impressed. And we had so many take-home messages as well. I'm so sorry to interrupt you as we are running short of time.
No.
So whatever questions we have, we may discuss it towards the end of the webinar. I would like to ask Dr. Sujata to continue further in the webinar.
Yeah, thank you. Thank you, Dr. Poonam. And this was really a flawless talk from Dr. Gauri. Now we have, this is, I think, only the webinar where we are having surgeon with us. And as we have already long waited as surgeon for induction, let us hear your surgeon's perspective for reconstructive surgery. So I welcome Dr. Rajendra Nehte, sir, for his talk. Apart from a good music collection, song collection, what are the requirements? Let us hear from sir. Dr. Nehte, sir.
Yeah, thank you. I'll share my screen.
Yes, sir, please.
Can you see my screen? And can you hear me?
Yes, sir. Yes, sir.
Okay. So in fact, after the 3 lectures delivered by Anita, Gauri, and our own Bijay, Sayogita, I don't think I have a place to speak because they have mentioned almost everything what I wanted to speak. But then it will be a little philosophical talk about the surgeon's perspective about anesthesia for reconstructive surgery plus the perspective about the anesthetist. One sec. So firstly, let me acknowledge ISA Miraj Sangli office bearers for inviting me for this webinar. And I must appreciate the cooperation extended by Dr. Ganesh Chaudhary and allow me to use his cartoons in the presentation. So if we see the anesthesia evolution, this is a mask being held by an anesthetist using a sulfuric acid and alcohol to anesthetize the patient, to a recent microvascular surgery anesthesia as delivered, a beautiful lecture delivered by Dr. Gauri. And she is almost mentioned everything in what is required in microvascular surgery. And I sincerely feel she should speak into a surgeon's conference. So why this talk in anesthesia meeting by a surgeon? So this is one of the cartoon by Dr. Ganesh, where he says batsman versus Superman, and it's a gasman versus sutureman. So in fact, my better half is anesthesiologist, and the poorer half as a surgeon understands anesthetics better than anybody else. And in fact, this talk also should be delivered in surgeons meeting because it is essential for surgeons to know better about the anesthesiologist. So there is a disclaimer, these are my personal views and may not be applicable in all the situations. So if we consider operation theater, most of the hospitals, they will relate it to patient and a surgeon. But there are very few hospitals where they will involve a third entity as an anesthesiologist along with the patient. So anesthesiologist doesn't come as alone. He comes with the team, because I always consider anesthesiologist who's in charge of a theater, who takes control of the theater. So the anesthesiologist will control all the other people, the paramedics, the assistants, the assistant anesthesiologist, and everybody encompassing. So it is, in fact, it is the duty of anesthesiologist to gather everybody and be very communicative with the all. And that is how this circle is completed. And when these three factors come together, I think we can have a best of the results. So the anesthetist, as it is, they have a great value, and we can't work without anesthesiologist. So what is plastic and reconstructive surgery? So if you see, there are so many fields where we work. Gauri talked about the breast reconstruction and so many flaps she showed. So, but then we almost work from head to toe in a reconstructive surgery. So there are so many, you know all of them, so I will not go into details. So where we work is Vedant Hospital, is a tertiary care center in plastic, cosmetic, microvascular reconstructive surgery, and focused on extremity surgeries. So we have almost now 26 years of experience into this field, and this is a dedicated hospital, and we have been working dedicatedly for this job. Now, this is the first case. 28-year-old male patient used to have assault by sharp weapon and presented 3 hours after injury, so he was well within time. And this is how we dissect the distal part. This is under the big magnification because we have very advanced microscope with us. And these are the anastomosis. This is repair of the tendons, repair of digital nerves. I will not go into technical details, but this was the on-table result. And this late follow-up after 2 years. You can't identify that his thumb was amputated. But what is the requirement? So surgical time was around 4 to 5 hours. And we do it under regional anesthesia with maybe sedation or intravenous general anesthesia. The main considerations in these patients is they come on emergency time. Anytime they come and we have to operate at any time. So this, you can see on the photograph, this is around 10 o'clock in the night. So many times there is no time for investigations and fitness, especially the fitness. Investigations we send and we wait for maybe 30, 40 minutes. In many times the patient is not NBM. And then you have to take care that you immediately you put an intravenous line, give them Reglan and give them, take them to theater as early as possible. What is more important is when you are doing this under regional anesthesia, there should be no movements during microvascular surgery, or when especially we are doing the microvascular anastomosis. Because when you are given regional anesthesia and patient is lying in that position for 4 to 5 hours, they become so uncomfortable. Many times, if we are finishing surgery fast, we don't put in the Foley's catheter. And because of the discomfort also, they start moving, and then it disturbs surgeon to a great extent. So it is the responsibility of the anesthetist to take care that the patient is not moving, and somehow you sedate them to a level where they don't become sedated, so that you need to intubate them or you need to supplement them with other anesthesia. But then it has to be a very adequate sedation. So when we started this at Nasik, we used to always give a landmark guided block. Then we started with PNS guided, and now we use USG guided, and it is very helpful. This upgradation from the landmark guided to USG guided help us to a great extent, because we can use this USG guided in other indications for any perioperative blocks for pain relief. We use this rampantly in diabetic foot. We use in elderly unfit patients. So all the types of blocks can be given with ultrasonography. This is another patient, 17-year-old male patient, came with complete avulsion of the arm at the shoulder level, and you can see his scapula is also there, which is avulsed, and this is the part of the clavicle. So this was in fact scapulothoracic dissociation from the body. So this was the shoulder. We have put the clamps on the vessels, and this is an emergency surgery, and we completed it. We can see the reconstruction of the nerve. And this is his video in a second post-op day. The surgical details, if you see, surgical time was 7 hours. So you can understand it was very quick surgery that way. But if you see the OT timing, it was 11 hours and 30 minutes. It was done under general anesthesia. So why did we take 4.5 hours more than the surgical time? Because, see, if you understand this, there is a lot of bulk which is devascularized in this patient in the arm and in the forearm. And if we want to replant this on the body, you are taking too much of a risk, because if you do a delayed surgery, all the muscles will be devitalized and there will be ischemic necrosis of the muscles and they will lead to a myoglobin release. So this is a reperfusion injury, what we call. And because of reperfusion injury, the patient will go into ARF and many other subsequent problems. And sometimes there are reported deaths in the literature because of trying to replant. The other situation, if you don't try to replant, the patient, the bleeding is already stopped, patient is good, you have to just close this stump after debridement and the patient is alive. So surgeon and the anesthetist has to appropriately decide whether at this center you can take a chance of replanting this and risking patient life, or not replanting it and making patient survive completely. So it is a great risk. So what was the problem intraoperatively? So there is extensive blood loss after the arterial anastomosis that leads to hypotension. There is a myoglobinuria, whatever time you say. So we did it in 7 hours. But then when we start the surgery, he presented to us after 3 hours after trauma. After that, we started surgery. And for the arterial anastomosis to happen and the circulate in the limb, it was almost around 6 hours. So it becomes borderline, because we believe if the good amount of muscle is devascularized for around 6 hours, then it will have irreversible necrosis and it will lead to a reperfusion injury. And there was acidosis to the patient. So the anesthetist team has to work very hard on this, and the whole surgical team and the anesthesia team. So almost 8 of us, all consultants, were around the patient for 4 hours post-operatively. And that is how we could have this successful. So we always do it, and we have been doing major replants consistently, and we achieve it consistently because of the dedicated team. But how do we reach this stage? It's because of the teamwork. Dr. Anita, all of you know, she is ably assisted by Dr. Yogita Bhamre, who's our associate consultant in anesthesia. Dr. Abhishek Kulkarni is my associate plastic surgeon. He's an excellent microvascular surgeon and a diabetic foot surgeon. Dr. Harshad Adav, who's an orthoplastic surgeon and trauma surgeon. And we strongly believe that this teamwork improves the quality of services, a surgical success, and a patient safety. So though this is only a 30-bedded hospital, because of our teamwork and because of the infrastructure what we have, there is nothing in plastic surgical equipments which we don't have. And that is how it makes us successful. So in a microvascular surgery, I think Gauri has explained it in great detail. I will go into the detail. Now, again, this is a patient with upper arm level amputation, and he came within 1 hour because he was from a nearby place, and we could easily transplant it, and he's got excellent function in his hand. But then in children, it is essentially because of the blood loss, you have to be very, very careful, and whole success depends on the anesthesia team rather than the surgical team, because anyway, we are going to do what job we are supposed to do. But he's got excellent function, and we did some secondary surgery, and you can see he's got excellent sensory recovery in the hand. Because of that, he can even pick up the small pins. So he's got intrinsic muscles are also recovered because of the good nerve repair. We frequently do leg replantations also. This I purposefully added because I wanted you to know something about it. In the first states, put only pressure bandage, don't apply the artery forceps. elevate it higher than the heart level and transport to the specialty center as early as possible. So don't try to catch bleeders by the forceps, and don't tie a tourniquet, because the tourniquet are left for a longer time. And there in the literature, there are many patients who have lost their limbs because of the tourniquet. How to transport this part is this little extra from this topic. I'm deviating, but it is important for all of you also to know. The part is wrapped in a plastic bag. It is sealed by a thread, and then put it into either a thermocol box or a small thermos if it is a finger, and put ice into it and transport it to the specialty center. And the aim is to increase the cold ischemia time. So what was the factors affecting the survival other than the surgical team and the anesthesia team? It's the mode of trauma. If it is a crush injury, there is less chance of survival. The cold ischemia time should be less than 4 hours. So within 4 hours, the patient should come, but then the part should be stored properly. There should be minimum hot ischemia time. So whenever you see the amputated part, immediately clean it with either plain water or a saline and put it into plastic bag and into the ice. The level of injury, the distal the amputation, the better is the result. But then whatever level we get, we always try to replant it. Decision not to replant is taken inside the theater after complete dissection of both the parts, and not in the recovery room. And the most important is we have little holistic approach towards these replantations, because when patient comes, they don't have any money for deposit, so we don't take any deposits. Whatever they have, they can deposit. Otherwise, we don't ask for we insist for a deposit, and we take them to theater. And we have a system and protocol established in such a manner that whatever emergency comes, if it is to be taken in theater, the within time of our theater and induction of anesthesia from patient arrival is just 40 minutes. So everything is ready within 40 minutes. So this was again 10 hours of surgery, and this is the patient who's walking on the same leg. You can see there is hardly any deficit in his walking. Similarly, when we do these major replants, we also do small finger replants. They don't have much of the botheration about anesthesiology, but then it is very important to have excellent regional anesthesia for a good survival of this. And as Gauri mentioned, all these patients will be should be hemodynamically stable. They should have hyperdynamic circulation to get the excellent results. So you can't identify later which finger was replanted. So very often we get this type of injuries. This was the 7-finger amputation, 8 fingers. So we decided not to replant one because they're at a very distal level. 7 we tried to replant. I started with the right hand. So this surgery patient came around 10:30 p.m. We started surgery around 11:30, and next day 6:30 evening we finished. So it was more than 36 hours. And but then most important thing, surgeon and anesthetist have to be mentally prepared to work day and night for such cases. And there has to be very strong determination. So we started with the right hand, and we could save all fingers of the right hand, but we couldn't save the fingers of the left hand. So it was unfortunate, but then he has an excellent function in his hand, and he joined back the same factory where he was working, and that gives us a motivation to work further in this field. So there are complex hand injuries, and very often we get this at night hours. Now this is a patient which was induced around 7 o'clock. This is on-table photograph. You can see time it was 19 p.m. And we started this surgery, and there were 2 fingers completely amputated, thumb partial amputation, index finger complete partial amputation. But then what we could save is this. So we could repair the thumb vascular repair, ring finger replanted. So, but then we replanted the middle finger at the place of ring finger to give the ulnar post. And then patient had a defect like this, which needed a free flap in the emergency hours. So this was around you can see 21:16. So it was around 9:15, and we went ahead with the free flap. Now what free flap to be chosen in such situation? So patient was only given the regional block. So we can use anterolateral thigh flap, a skip flap, which is from the groin, or a lateral arm flap. So there is significant advantage of using a lateral arm flap in this situation, which is taken from the same limb, which is anesthetized already. And so in the same anesthesia, it can be harvested and it can be done. So usually and this was around 3 o'clock, you can see when we finished, and this was on table post-op. But then it is very important that we use the same anesthesia for the harvest of the flap. So one anesthesia, one stage procedure, and it has distinct advantages. It increases safety to the patient. There is early recovery of the patient because there is only one hand involved. There is early rehabilitation and early return to work, leading to significant reduction in the expenses and lots of money saving. Being a nationalist, I always feel that we should save as much of money as possible, spend only on the essential things. This was student of 6th standard, right hand firecracker injury, complete amputation of the thumb and incomplete amputation of the ring finger. So we should always look at the larger picture in this. Now, do not look at him as one of your patients. This is the right hand which is traumatized. He won't be able to write. So he has to shift his handedness to the left hand. It can affect his studies and overall performance. There is lack of good education, inferiority complex due to poor peer pressure, the lack of earning capacity of one person, and there are poor marriage prospects for this patient if we don't do this properly. So the end result is the one generation of family is wiped out of their resources, and in spite of that, he doesn't have a good result. So it is very essential to give this type of result. So we worked almost for 14 hours and gave him this result. He's got excellent function in his hand. But then this is a child. It has to be done under general anesthesia. So this was almost 14 hours we were working because there were 2 fingers involved, and we did a flap, transposition flap. So for 14 hours to maintain a child under anesthesia, so it's a great responsibility towards anesthetist. We literally test their patience many times, but that gives a very rewarding result. Another patient, 22-year-old male with crush injury of the forearm, he was advised amputation somewhere. So we debrided, and then we did a large flap. This is probably the largest flap which I did, the 45 centimeter length of the flap to be inserted on the arm. So this is again under general anesthesia. And then we did secondary surgeries for him. He had some flap necrosis. We did another flap, a free flap after a few days. Then we did median nerve repair. And this was his pre-op picture, and this is his post-op picture. So he's an engineering student, 3rd year, and he has got good recovery in his hand. And he recovered his good function. I don't have his recent late post-operative video, but he's got excellent function and is doing normal work. So we published this in the hand clinics as challenges posed by delayed presentation of mutilating hand injuries, because many times we don't get these patients in emergency hours. Then I'll mention about the specific surgeries. So what we do is toe to thumb transfer. This was a patient with had a thumb amputation. So we do second toe transfer in such patients. So this is the second toe which is harvested. So you have to give anesthesia to the limb also. So what anesthesia we give? We use epidural plus spinal. So patient is firstly induced in, he is taken into theater in a sitting position. We give epidural and spinal anesthesia. Patient lies down and then we give a brachial block. But till the times, many times what we do is under epidural and spinal, we start the surgery, we harvest the toe, keep it intact, attached. And then when we are finishing that, it takes around maybe 1 hour or 1.5 hours. After that, we give a brachial block and start surgery because we are going to take a little more time out here. So, but our surgical time is around 4.5 to 5 hours for doing a toe transfer. So you get excellent result with this. And you can see every work, what he's supposed to do. There is engineer himself, a factory owner, and he can do all the job he was supposed to do. He can lift the heavy object. So this beautiful reconstruction. So we had another patient, similar amputation, bilateral hand. We did second toe transfers. You can see there is no deficit in the foot. The same anesthesia again, the spinal plus epidural and plus brachial block. And we are very, very comfortable with this. And this patient has done exceedingly well. And there is no donor site morbidity in the foot. and we published this in the IJPS as bilateral microvascular toe transfers. So we do such toe finger reconstructions also. These are all prolonged surgeries. Now this transferring these two toes with the free flap, and then when we harvested the two toes, we realized there was a defect out here, and it immediately needs to be treated. So we did a free flap on the same thing. So this is a free flap again, and then you see a end result, a beautiful reconstruction. Though it doesn't look good, at 2 years, his hand was functioning in a normal manner. And now he is grown up. After 11 years, he's working as a teacher, and you can see he can do almost everything what is required for his day-to-day living. In fact, he can do all the work which is supposed to do, and this is one of the difficult job: folding and unfolding of the sleeves and buttoning and buttoning of the shirts. So by bilateral hand amputation, it was very difficult. So we did, this is another landmark case in the world where we have done 6 toes transfer. So 3 toes and 2 free flaps for one hand, 3 toes and 1 free flap for the other hand. So it doesn't look good, but then his function is normal. He is working at joined back his own factory, and he can do all the activities of his daily living very well. So this is got some modified work in the factory. You can walk. So we do a lot of mini micro flaps also. This is the index finger injury, and he needed a small flap. So we did a pre-innervated thinner flap. The flap dimension is 2 centimeter by 1.5 centimeters. And you can see a beautifully reconstructed index finger. He's got a good nail now. He's got a glabrous skin on the index finger. You can't identify that it is really a flap. Another important is brachial plexus injuries, wherein it is required. He did not have the movement in the upper limb, the shoulder and elbow. What is more important is we need a stimulation in these patients to see whether the nerves are working or not. So this is the first step as a phrenic nerve stimulation. For this, when we give anesthesia, we don't give any muscle relaxant. So there has to be good communication between the anesthetist and a surgeon to perform these surgeries. So when they can give muscle relaxant and when they cannot give. And this is a nerve graft. These are the nerve repairs what we did, and this is function at 8 months. So he's got excellent function at elbow and a shoulder. So good anesthesia will always give a good result. This was a patient with lower limb trauma, needed a free flap, again a free flap. So in an adult patient, whether you need always a general anesthesia or whether you need only epidural and spinal. So if you are working on the legs, as even Ganesh has depicted, epidural and spinal serves very well. So this was a free flap which was done. Later on, we did a free microvascular fibula transfer also. And you can see a good reconstruction and good patient walking on his foot. So many times we get small children. This is a small boy with foot injury. So I'm not mentioning much detail about the microvascular surgery because Gauri has covered it completely about everything about the free microvascular surgery. But I will depict what if you convert into a surgical practice, what success means. So initially, when we started at Nasik, almost 26 years back, we had a failure rate of around 10%. Over the years, we could get it down to 2%. So we explain it to the patient and do a surgery. So this was a big anterolateral thigh flap, which was done. And after 8 months, and if you see after thinning of the flap, you can see a very good flap. Very, very important that you do this surgery very well, and it has to be successful, because then only, if it is matching to the opposite limb, then only patient can wear the same footwear which he can wear in the opposite limb. Otherwise, they have to buy 2 footwears. Another patient we do, this is again a 6-year-old girl. She had a heel avulsion injury, a very small flap from the parascapular area. And we do this frequently, a mini micro flaps. So for some of these patients, you need a general anesthesia in a lateral position. And Dr. Gauri has explained it. You need to have proper restraints. Then put the pillow under the lower side of the axilla to avoid pressure on the brachial plexus and the vessels. Avoid all the pressure points and be careful. Use silicone pillows everywhere so that you don't get pressure sores. Head and neck, again, very important point. This was a scalp avulsion. So you can see a suture fixation of the tube. So many times I find that many anesthetists, they try to put dynaplast out here and it remains unsterile. So we don't want anything unsterile out in the surgical field. So we have anesthetist tray where they use the suture material. This is our tray where they fix the tube with the sterile material. It is kept in always ready. And this is the patient. Again, for such patient, when we are replanting this scalp, we need a frequent movement of the tube and frequent movement of the head. And that necessitates that your tube fixation is very, very secure, because we are doing anastomosis on one side of the face, then the opposite side of the face. We will check it again. And if we have to revise, then we will again change the position. So it is very important that the airway is secured very well. This is another, and this is she after there was anterior portion is gone because it was badly traumatized, but overall she is extremely happy with the result. Then face reconstructive surgery. Sanyogita has already talked about the burns reconstruction. She had all the difficulties about burn reconstruction, but where it makes a difference. Now we have come to this stage, and at this stage, patient said, "I don't want to live like this. You do something for my face." So what we did is we expanded her back, and again this needs a lateral position. Patient is operated in lateral position, has to stay in 3 months for lateral position. And this was the face replica which we put on that expanded flap. And this is the flap. We have removed the facial skin and did the microvascular anastomosis in the neck. And then now you can see there is a tube which is going through the oral cavity. And I want to put this flap on the total face. So you have to extubate this patient during anesthesia, during surgery, and re-intubate it after putting a hole. So you can see now this is a re-intubation into the oral cavity. So later on, so because we couldn't decide at what place the oral orifice will be in the flap. So unless you drape it, you can't judge it. And that is why it requires a re-intubation, and you need excellent cooperation from anesthetists for this. So the teamwork involved a good collaboration, good discussion about everything. And this is at the end, and she has done extremely well. So you can see all the 3 photographs, many surgeries, but then at the end, she is extremely happy. So oral onco reconstruction, she has talked about it. So what we believe is you need a very strong communication and collaboration. So there has to be effective teamwork and communication between surgical and anesthesia teams. Every minute point has to be discussed properly. Then address the challenges and unforeseen circumstances together. It is very, very important. It is very important that all the anesthetists, especially in the freelancing practice, those who are not working in the institutions, they need to assess the patients preoperatively very well and plan anesthesia very well, discuss it with the surgeon. Then only you can embark on the major reconstructive surgeries. There has to be very tailored anesthesia based on patient's medical history. And it is very important to assess the patient in preoperative care for this. Ultimately, all of us are working for patient safety. So monitoring of vital signs and responding to complications is essential from the anesthetist point of view. And the role of anesthetist in ensuring patient safety throughout the surgery is very, very important. And as a surgeon, we strongly believe into it. As well, we have to always take care of post-operative pain management and the patient comfort, because we always look at it being, I'm running my own hospital. And if you have to create a goodwill amongst the patient, the whole experience of patient in the hospital has to be good. And to make it good, in fact, anesthetist has a bigger role. So it is essential that patient should not have any post-operative nausea vomiting incidences. That makes their recovery very smooth, and that creates a goodwill amongst the patient that the surgical team and the anesthesia team in this hospital are excellent, and they work toward patient safety and towards the good result of the patient. So this collaboration in managing patient recovery amongst the surgeon and patient is very, very important. So because the whole anesthesia itself leads to a higher incidence of nausea and vomiting. And I'm proud to say that in our hospital, the incidence is less than 1%. And because of that, our experience of our patients is very nice. as well, the anesthetist has to give a value addition to the hospital, but then from the surgical team, there has to be appreciation for collaborative efforts between the teams. And there has to be continuous upgradation of knowledge and skills. But there are bound to be some conflicts. Because of the professional decisions, there might be some conflicts, but I think personal conflict is not healthy and it is not in the best interest of the patient. So we should always try to avoid these conflicts. So there are many negative perceptions about surgeons from the anesthetist point of view, because the surgeon may not have a good knowledge about medical and anesthesia related issues. The failure to perceive or acknowledge the extent of blood loss. And in fact, this is one of the good cartoons by this thing, that the surgeon is having a blood bath. So there has to be consistent underestimation of the surgical time. So if the anesthetist comes and they ask, sir, how much time you will take? And if you say 1 hour, it has to be finished in 1 hour and it can't go for 3 hours. Especially for a freelancing practice, many people have taken 2 or 3 cases in a day. And if they are delayed unnecessarily, it becomes a problem. So from a surgeon point of view, it is very important to take care of this. Then there is a failure to explain to the patient and families about the likelihood of success and magnitude of difficulty in recovery, as well as complication. So many times they are not very well explained. I think it is the teamwork where the anesthetist also need to know the complication, and they need to know that this has been explained to the patient. There has to be, many times there is failure to adequately consider patient health conditions and patient desires. So in the teamwork, you can't allow this. As well, there are negative perceptions about the anesthetist. Sometimes surgeons feel that anesthetists are more concerned with finishing their day. So sir, finish it fast. We have to go. We have another appointment or we have another case. I think that has to be discouraged, because if you have given time for this one surgery, it has to be completed properly. Sometimes there is unreasonable eagerness to cancel a procedure based on unjustified concerns, and these are becoming less and less. I think it was there because of the lack of equipments and lack of poor training in the era where there were poor quality of drugs. But I find in recent time, this is much less. And in fact, anesthetists are very eager to give more and more cases. Then there is unappreciation of the need to maintain schedule. So this is many times surgeon complain this, but the same complaint is from anesthetist side also, that surgeons don't keep their time. There is distraction and inattention during surgery. And this is the time, many times the anesthetists have a mobile in their hand. And in recent times, I find many anesthetists working on the sensex rather than working on the patients during anesthesia. And I think that has to be strictly condemned. There is failure to follow the aseptic techniques, because many times, as Gauri said, we have a lot of draping to the patient, whole 4 limbs and everything is draped. And suddenly there is some mishap, there is disconnection of the tube and they will throw the drapes. Yes, for patient safety, it is very important, but it is very important to secure them beforehand only. Then there is failure to communicate important changes in the vital signs to the entire team. So it is very important that the anesthetist discusses all the problems, vital signs to the whole team, and the other assistants are very good. Sometimes they are apprehensive because some surgeons are not very receptive about it, and that is why they don't discuss. But I think there has to be open discussion. So I'll skip 1 or 2 points. So there are different values for both. The surgeon and anesthesiologist have different jobs that can lead to a different values and motivations for what they see as best for the patient. But then it is a part of training, and it is some partly depends on the ethics also. So I think the team has to collaborate well, and their ethics and their motives, they have to match very well, and that is how they can form a good team. But in spite of that, even the best people and the best relationships have some rocky times. It happens. And I know enough of the situations where problems in surgeons and anesthesiologists relationships have been harmful to the patients. I think that has to be strictly avoided. So what leads to success in the teamwork? The respect for each other, the trust in each other, You have to have a good ear to listen to each other. Seek opinion from the other. Be a good critic. Whenever you don't like it, you have to mention it. Maybe very politely, but you have to mention it. Encourage others to perform better and better and to upgrade their knowledge and skill. You should have empathy towards your colleague because you know what they are going through. There has to be very, very strong determination, and the hard work involved is always there in this. So over the years, we strongly believe this JRD Tata statement that productivity and efficiency can be achieved only step by step with sustained hard work, relentless attention to details, and insistence on the highest standards of quality and performance. I think that leads to a good success. And if we want to be a successful surgeon or a successful anesthetist, I think everything involved mentioned in the statement has to be followed properly, and that will lead to a good success. So this is one of my passion. Last year, what we did Annapurna circuit trek, and this was at Thorangla Pass, around 17,000 height. And thank you very much for inviting me for this beautiful webinar. In fact, I also learned many things in this.
Thank you, sir.
Thank you very much.
Yeah. Thank you so much, sir. It was a wonderful talk and insight with a phenomenal result of reconstruction and the real images of your patient. The quality of work and the teamwork, as well as the holistic approach, I really do a hats off to your work at Vedant Hospital. Thank you so much.
Thank you very much. I'll be very happy to answer if there are any questions.
Yeah, I think Dr. Rupali wants to say for 36 hours, the surgery which you did, what was the anesthesia given for 36 hours?
See, what we do in such situations, if we always do it under brachial blocks. So this was a bilateral brachial block. But when the patient complains of the pain in one hand, we repeat the block because there is no harm in repeating the block. And till that time, the dose of anesthetic which is required for the block also doesn't extend. So it doesn't matter if you repeat the block.
Even the continuous block can be given, like supraclavicular continuous block.
Yeah,
we can give it.
Yeah, we have tried it, but the effectivity of the continuous block by the catheter is not very well. So
as compared to that.
So the ultrasound guided block, which can be we can all see all the nerves and give appropriate. Because continuous block, there is only one hole to the catheter, and from there, what amount of drug you need is very high. Whereas in a sono-guided block, the amount of drug you require is very less. And I think this is a great advantage.
Yes, Sujata, continuous blocks also we can give, but the thing is with sono-guided, at a time you give only 20 cc solution, and the next, within 6 hours, you can repeat another block within 8 hours. So one anesthesia for supraclavicular with 20 cc will last for around 8 hours.
8 hours, correct.
Yes. So you can.
It may give around 8 to 10 hours. The effect may prolong even with the additives as well.
Yes,
additives with the exam.
Continuous what happens, the gauge is very small. It's a 20 gauge catheter, so it can get blocked, and with the movement, it can get dislodged. So, and you won't know if it's dislodged unless and until you wait for the action. So it becomes, in the surgery, the movement is continuously going on. So the catheter dislodgement.
If the field is nearby to your block area, so can you use the ultrasound via all the sterile techniques for the second dose infiltration?
So what we do, we stop the surgery. The surgeons take a break, and we properly under aseptic technique, we repeat the block. Then drape it again.
Yeah. Wonderful, ma'am. Wonderful talk.
It is very important. I mean, 36 hours instead of giving general anesthesia, if it is happening in regional, the results are much better. The physiology is much
much preserved. Right, correct. But even keep the patient calm for 36 hours. What sedation, minimal sedation you have used?
I continuously use the Butram and midazolam. So I keep on repeating after maybe 3 hours. Every 3 hours I repeat.
So you are giving top up, ma'am. Boluses only, no infusion continuous.
No infusion. But now that we are going to have remifentanil,
it's available, na?
We might use, yes.
So many of these are extremity replant patients when they are lying in a supine position. In fact, they get low backache and they start complaining of low backache. So
Yes.
what we do is under the drape, we ask them to fold their legs.
Yeah.
So somebody assists them. So there has to be some active cooperation from whole team to take care of the patient. Because obviously, if we lie down in a supine position for such a period, you can't really lie down in one position like this. It is very,
No,
very.
definitely.
So what we do, we plan the patient. Suppose the patient is going to become out of sedation in this time. So we plan that the surgeon and everybody takes break at that time. We ask the patient to move the legs, do movements.
Right.
And then when the team starts again, we again sedate the patient. So
That's
the patient is also comfortable.
Yeah, exactly.
So, ma'am, while repeating the blocks, the additive which we used in first time, so again we repeat that additive, or you were just giving the plain local anesthetics?
I repeat the dexamethasone. I use generally dexamethasone as an additive. And now recently I have started using dexmedetomidine. So dexmedetomidine blocks are very, very long. The 14-16-hour blocks. You really don't need to repeat them.
So dexmedetomidine in 1 microgram per kg in block also? Same dose, 1 max per kg?
0.5.
0.5.
There are, I mean, they have no studies with 0.5 mics or even 1 mic per kg, but I use 0.5. It really prolongs the block.
Yeah, so
Almost
nowadays,
14,
what I experience in ward is if the block is given around 10 o'clock, 11 o'clock in the morning, normally the action wears off around 12 o'clock in the night. And we need to give, and they start complaining of pain around that
Pain.
time, that we got some pain and some feeling. Till that time, the hand is paralyzed. So it is a very long acting because of the Dexmed.
Excellent, excellent. Yes. Any more question? I think, Rupali, we can conclude the session as.
Yeah,
Yeah.
one more question to Naik ma'am, that if the patient is having scar over the back and having lower limb surgery, so can we give regularly regional anesthesia, or is there any, we have to change our technique? Because if there is a big scar on the our spinal area or neuraxial, can we proceed? Ma'am, please
Madam,
unmute.
you are muted, madam. Yeah, you will have to unmute yourself.
Rupali,
हाँ ma'am.
hello.
हाँ हाँ,
If
hello
there
ma'am.
is the scar tissue and not able to give the spinal anesthesia, then the other techniques we can sciatic block with femoral block
No, I'm not
or
asking
low
that other
extremity.
techniques, but I think there is a might be difficulties giving the neuraxial na. Is actually I'm not come across such type of patients, but if patient is having chronic burn patient and posted for the lower limb surgery, chronic burn over
Yes.
the back, so routinely we go with the regional neuraxial anesthesia, or we go with other techniques. That's what I'm
If
asking.
no, if
Can we
black
try?
site is available for the spinal, then we can give the spinal. But if spinal we can't identify the space because of scar
But
tissue,
with USG
then
machine,
we USG guided you can proceed the procedure through the USG guided epidural or the spinal we can give, or other blocks like the sciatic block with femoral block we can give.
Just the
Yes.
presence of the burn scar is not a contraindication, is what madam.
Burn scar
yeah,
is
yeah,
not
I
contraindication.
Unless
just
it is not
Technical
infected.
difficulties that you can't
difficulties.
find out. Yes. But USG guided nowadays, it is very useful. Yes.
Okay, then we conclude.
Very nice talk, with Dr. Nehte.
Thank you, ma'am. Your talk was also very nice. I
No,
learned
no,
something from your talk.
I just wind up actually, but it's great. 36 hours surgery is great, really.
Even the facial
nice.
reconstruction which you showed, and where you need to extubate the patient and again
Yeah,
reintegrate, that is again a challenging case. I think
Yes.
if Nehte madam had done the case, so madam, you can just throw a light on the case.
yeah. I also want to know that how it.
Exactly.
Actually, all that the surgery, the raw area was outside her face. So inside
Yeah.
her mouth, there was no blood. And
Right.
and suck out and re-intubate. She was a very thin patient, so I pre-oxygenated and changed the tube. She had a very long, the safe apnea period was very long because she was very thin. And after pre-oxygenation, I could easily change. She did not even the saturation.
Flap. Were you able to open the mouth adequately?
Yes.
Yes, after
No, actually,
So putting that flap.
You
I
can put the boogie,
intubated after the flap was reversed on her head. I
Okay.
intubated on the raw area.
Acha, on the
Only
raw
tube
area.
end was removed.
Okay.
Only the tube end was removed through that, where the prospective lips would be.
Then why not afferent tracheostomy was preferred in this patient, Miss?
Because of
we wanted
scars.
to avoid tracheostomy, ma'am.
Sorry, sir.
We
why?
wanted to avoid tracheostomy, and that is why we re-intubated it.
But again, to
Sometimes it is
I know.
Sometimes it is advisable.
It is. So
Hmm.
it is a question of, I always say like this, if you think of tracheostomy, you should do it. But then,
yes.
I think we have a protocol that I call myself as a poorer half, because whenever induction is going on or whenever this critical thing is going on, the whole surgical team is there around, so that that nothing goes wrong.
Anytime you can go for the tracheostomy if
That's
at
a
all at
fixed rule.
crisis.
That is fixed
So
rule in the hospital.
that's why your team took the challenge and you did the challenging case.
No, mainly head
That's
neck
it.
reconstructions with large bulky flaps. It is better to do tracheostomy because the patient might need re-exploration and the flap really swells up in the post-op, or it keeps on.
Even the bilateral neck dissection is an indication for tracheostomy,
Yes,
so as to maintain the airway passage, right?
there is
Exactly.
no other way to manage it then.
Exactly. Thank you so much, sir.
Thank you very
Thank
much.
you, ma'am.
Thank you.
Thank you, everybody.
Thank you.
So we conclude the session. On the behalf of our ISA Mira Sangli branch, I would like to thank all the speakers, Dr. Anita ma'am, Nehte sir, Sanyogita ma'am, Dr. Gauri Ganga Khedkar, for giving their valuable time and throwing very good insight on the each topic and sharing all the real-time pictures and making this session very interactive and interesting. I also, my sincere thanks to Dr. Poonam Ghodke ma'am and Sujata Zine ma'am for excellent moderation and for giving their valuable times. I'm also very thankful to Sam's office bearers for giving this platform. And I would like to thank Mr. Ganesh and Jenica Technology for giving this uninterrupted digital platform. And thank you all the delegates for attending this nice webinar. And thank you all. Good night.
Thank you.
Good night.
Rupali. Thank you.
Thank you, Rupali. Good night. Thank you, madam.
Thank you, ma'am. Nice meeting.
Yes.
Thank you, sir.